Good morning, everyone. Well, I guess it's morning here. It's different times in different places around the world, with everyone joining us today for the fourth Cardio-Rheum Symposium, Targeting Inflammation, Emerging Approaches to Reduce Cardiovascular Risk. My name is Paula Harvey, and I'm here with my colleague, Dr. Lihi Eder, to be leading the sessions for today. So, why are we here talking about cardio-rheumatology? The one thing we've learned over the years, myself and Dr. Eder, is that there is a very high cardiovascular risk in patients with inflammatory rheumatic diseases. In fact, with all of our targeted therapies for rheumatic diseases, cardiovascular disease is now the #1 cause of death. For example, the risk of a myocardial infarction in a patient with rheumatoid arthritis is the equivalent of a patient without rheumatoid arthritis who is 10 years older, very similar to what we see in patients with diabetes. The increase in risk of cardiovascular disease does vary with respect to the type of inflammatory rheumatic disorder that we are addressing, and it can range from 30 to 70% increased risk. Now, one of the things that we have identified in our patients and others with research is that there are very significant gaps in the care of cardiovascular risk factors in patients with inflammatory rheumatic disorders. This bar graph is taken from a publication that was led by Dr. Eder, published in 2018, looking at a large cohort of over 2,000 patients with psoriatic disease and psoriatic arthritis. And as you can see, we're looking at the number of patients who had diagnosed and undiagnosed cardiovascular risk factors. It's very remarkable to see that up to 36% of these patients had undiagnosed dyslipidemia, and a significant portion also undiagnosed hypertension. And then there was a high prevalence of obesity, smoking, and diabetes. So there's a lot of work to be done to be addressing cardiovascular risk factors in these populations. So at the University of Toronto, we have a university-wide cardio-rheumatology program. The mission of this program is to improve the management of cardiometabolic diseases in rheumatic patients. And we really are addressing the 3 areas of clinical evaluation, research, and education. So in the clinical sphere, we have a primary prevention clinic that's based here and at Mount Sinai Hospital. And we also here at Women's College Hospital have a referral centre for patients with complex cardiovascular disease. And that includes not just atherosclerotic disease, but these patients are at increased risk of a myriad of other cardiac and vascular complications, some of which we'll hear about today. We're conducting research, studying, as I showed you on one of the previous slides, mechanisms of cardiovascular disease in rheumatic patients, and that includes the burden of cardiovascular risk factors. And we're working to standardize clinical imaging and laboratory data. We also feel that it's very important to be doing knowledge translation and education, and that involves transfer of knowledge to clinicians, researchers, and to patients. So I mentioned at Women's College Hospital, we have a program for primary prevention and for patients with complex rheumatic diseases that affect the heart and blood vessels. And this picture needs to be updated. Like many of our pictures, it's taken well before the pandemic, but this is a number of the members of our Cardio-Rheum program here at Women's College Hospital. And as I mentioned, we have a wider network across the University of Toronto, and that includes at Mount Sinai Hospital, the Cardia program that is led by Dr. Bindi Kuria, who is a rheumatologist and assistant professor, clinician investigator at Mount Sinai Hospital. We also partner with vascular imaging and cardiac imaging, and Dr. Elsie Nguyen and also Kate Hanneman. These are 2 radiologists who are part of our Cardio-Rheum network at the University of Toronto. If you want more information about our Cardio-Rheum program and some of our publications, the work that we're doing, some educational information, please do visit our website, cardio-rheum.org. Now, this is our 4th Cardio-Rheum Symposium. So the first couple were in person in 2018 and 2019, and you'll see on the slide here some of the participants in those Cardio-Rheum symposiums. And because of the pandemic, we then went virtual, like virtually every organisation across the globe. And today we're really pleased to have participants joining us really from across many international locations. So we're really talking to people from a lot of different time zones. That includes across the provinces of Canada. We also have people joining us from Chile, Germany, Jamaica, Kuwait, Mexico, Sweden, United Arab Emirates, the United Kingdom, and the US. So we want to welcome you all, and we really appreciate you joining at all different times of your days, and we hope you enjoy this symposium today. Now, we have the agenda that's divided between the morning agenda and the afternoon agenda. After I complete these welcoming comments, I will be handing over to Dr. Eder and my colleague, Dr. Akhtari, who are going to be giving an update of the year in review of cardio-rheumatology. We'll have that followed by Dr. Jean-Claude Tardif, who will be talking about colchicine for the prevention of cardiovascular events. He's really the world expert in this area. We will have a short 15-minute break when people can stretch their legs and do what they need to do in that 15 minutes. We'll move on to Charlene Compher, talking about inflammation, malnutrition, and how to identify malnutrition in adult ambulatory clinic patients. And then Dr. Buch will be talking about Scleroderma and cardiovascular disease. At the end of those sessions, we will have a panel discussion where all of the speakers will be happy to answer questions, and we hope that there will be a really interesting discussion. We do hope to have time for just a few minutes after each presentation where some questions can be answered depending on how our timelines. So probably questions during the course of the morning and then with the panel discussion. In the afternoon, we have a number of speakers. Now, I will mention that the order of the speakers has changed for the afternoon. We will be starting with Dr. Nehal Mehta, who will be talking about vascular inflammation in patients with psoriasis, and then moving on to Dr. Michael Garshick, who will talk about platelets and inflammation and the role of aspirin, a rather sort of controversial area these days in cardiovascular risk prevention. Then myself and my colleague, Dr. Ocean Token, will talk about clinical pearls in the Cardio-Rheumatology clinic. We will then finish the afternoon session again with a panel discussion with all of the speakers. So once again, feel free to be entering questions into the chat. We'll try and address some of those questions after each session, but then we can address a variety of questions during the panel discussions. And then we'll just finish with our closing remarks. So please post any of your questions into the chat box, and we'll be fielding those questions and collecting those questions. Also, you'll notice on your platform there's the opportunity for virtual networking. So we encourage you to interact with other conference attendees using the networking tab. This is on the left-hand menu, labeled networking, and you can click on Start Chat. You can send chat messages to one another, or you can actually join video calls. Now, this is an accredited event, so if you need a certificate of accreditation and attendance, this will be available to download once the symposium has been completed. This is also, the symposium undergoes evaluation after each symposium. So it's kind of an iterative process where we take in comments and recommendations and questions from the participants. And so we'd really appreciate if the participants, if all of you can take just a few minutes to complete the evaluation survey at the end of the symposium, because this really does help us improve future conferences and to make sure we're addressing the needs of our audience. Our audience is rather varied. We have rheumatologists, cardiologists, we have learners, we have nurses, family practice docs, allied health. So we're trying to make sure that we fulfill the needs of all of our different participants. So if you have any questions or technical issues, please reach out to the live support chat, which is on the bottom left-hand side of your screen. There is somebody here with the platform that will be able to help you if there are any issues. So click on technical support and you will receive that assistance. It's also important to know that all of these sessions are being recorded. This actually allows you to view these sessions at a later date. The content of this platform will be available for 6 months. And while the sessions won't be posted immediately, within a week, you'll find that these sessions will be available for you to view at your own convenience. We will send out a notification once that these sessions have been uploaded. Finally, I would just like to acknowledge all of our sponsors that have helped us to be able to provide the support for this symposium today. This is through educational support, and all of our sponsors listed here have provided these educational grants for us to continue to produce this symposium. Now, that's all from me, and I do hope everybody enjoys the symposium today. Once again, I emphasize, put any questions in the chat, and do feel free to communicate with one another throughout the symposium. It's always difficult to network when you're on a virtual platform, but we do have the tools for the chats and the video chats. So with that, I'm going to hand over to Dr. Eder and Dr. Akhtari, who are going to be presenting the first session today, which is looking at really a year in review of cardio-rheumatology.
Hello, everyone. I'm glad to be here and welcome. I'm really grateful that we were able to hold this event for another year. I'm going to start this session that is reviewing the important studies that were published this year. I'm going to start off with studies mostly published in rheumatology journal as a rheumatologist, and Dr. Akhtari will follow me with studies that were published in cardiology journals. So I want to emphasize that there was no structured way of identifying these studies. There were a lot of very interesting and important studies. We have limited time, so we really focused on things that this is our own personal opinions, and thought that this would be of interest to the general audience. These are my disclosures. And we can't really start this one-year review without discussing the oral surveillance study. So the rheumatologists in the audience, I'm sure, have heard a lot and participated in many discussions about this study. But since we have a very heterogeneous audience with people from different disciplines, we are going to mention this study as well. So the oral surveillance study was a study that was published earlier this year in the New England Journal of Medicine, and it studied the safety of a relatively new mode of action of advanced therapies, the JAK inhibitors, that are now used in several rheumatic conditions, and also received approval for the use in other fields such as dermatology and gastroenterology. So a brief overview of JAK inhibitors. So JAK or Janus kinase inhibitors are targeting receptors that appear or downstream or mediate the downstream effects of several pro-inflammatory cytokines. So unlike targeting a particular cytokine, they provide a more broad effect that could target the effect of several pro-inflammatory cytokines. As I mentioned, they are approved for rheumatoid arthritis, which was the first indication, and then they were approved for other indications in rheumatology as well as ulcerative colitis, and are being tested for other conditions. They provide an oral option, unlike the injectable biologics. They are non-immunogenic, and they are well tolerated by patients, and they offer a very effective option for patients who also fail several biologic medications. So they were first approved in 2012, and the first indication was rheumatoid arthritis. And during the development phase of tofacitinib, which was the first JAK inhibitor approved, there were concerns regarding cardiovascular safety and thromboembolic events, and therefore the FDA mandated this safety trial that was called oral surveillance. And this study attempted to assess the risk of cardiovascular events and cancer in patients who were at high risk. And so it enrolled patients who were 50 years of age and had at least one cardiovascular risk factor, and they randomized them into one of three groups. There were two groups of tofacitinib with two different doses, and a third arm was TNF inhibitors. The TNF inhibitors are known to be safe for cardiovascular events and potentially even protective. During this, the course of the trial, there were concerns regarding high number of thromboembolic events in the 10 milligram arm of tofacitinib, and therefore all of the patients were switched to a 5 milligram arm. And currently, the only dose that is approved of tofacitinib in rheumatic conditions is the 5 milligram arm, or 5 milligram per day, 5 milligram BID. So this trial was a safety trial, and there were two co-primary outcomes, major cardiovascular events and cancers, and it was designed as a non-inferiority trial, meaning that the upper bound of the confidence limit should not be more than 1.8. And as you can see from the results of this study, these are the cardiovascular events. This study did not meet its primary non-inferiority criteria because for both of these treatment arms, as well as for each individual arm, you can see that the upper bound of the confidence interval is more than 1.8. Similarly, for thromboembolic events, so DVT, pulmonary emboli, you can see that for, again, both of these arms, the upper bound of the confidence interval was more than 1.8. For the 10 milligram arm, it was even statistically significant. So the lower confidence interval was more than 1. So the results of this trial generated a lot of discussion because the JAK inhibitors are used quite widely in rheumatology, and it triggered black box warning from regulatory agencies, including the FDA, which was actually a very broad warning that included not just tofacitinib, but all JAK inhibitors. Health Canada also issued this warning, and this was more focusing on tofacitinib, where they suggested avoiding the use of this medication in patients who are at high risk of VTE, such as patients with a history of VTE, and to use it in caution with patients who are older and have cardiovascular risk factors. So obviously this generated even more discussion and some confusion as how to interpret these recommendations and warnings, and should we consider all JAK inhibitors as if they confer this risk to the same level? Does it apply to all rheumatic condition, not just rheumatoid arthritis? And we're still learning, and I think one of the interesting things that it generated is that there are now more and more studies into real-world data of how to apply these recommendations. And this is one interesting study that I wanted to highlight from the US that was published again earlier this year in Annals of Rheumatic Diseases. And this study tried to replicate this oral surveillance cohort in real-world data from the US. So they used a very large database and included over 80,000 patients. They called it real-world cohort, and these were patients who were initiating treatment with tofacitinib. And they also had a smaller subset of patients who met the inclusion criteria for the oral surveillance, and they called it RCT duplicate cohort. And they evaluated the risk of MACE in these patients. So I'll draw your attention to the lower box here, which is the RCT duplicate cohort. And very interestingly, they show that the hazard ratio was very similar to what was found in the oral surveillance study, with 1.24 hazard ratio, which was similar to 133 that was identified in the oral surveillance study. These were high-risk patients. But very interestingly, when they included all patients, irrespective of their baseline cardiovascular risk, and this was compared to TNF inhibitors, they did not really find any difference. So the hazard ratio was close to 1. So I think we need some more data definitely in other diseases and about different other JAK inhibitors, but I believe it all comes to a risk-benefit ratio and each individualized therapy based on the baseline risk for patients. So this, we need to think that to keep that in mind when we consider tofacitinib for therapy in our patients. Moving on to another study, and this study dealt with mechanisms and the association between rheumatoid arthritis and cardiovascular diseases. This study was published in Arthritis and Rheumatology, and also there was also an associated editorial. And this study considered or assessed the association and whether rheumatoid arthritis is actually an independent risk factor for cardiovascular events. We all know that cardiovascular diseases are increased in patients with RA, but there is still observational studies are subjected to different types of bias, such as residual confounding. We can't always adjust for all of the confounding factors. And it's also possible that RA is causing some of the traditional cardiovascular diseases. So in this study, they used a unique method that is called Mendelian randomization approach. And this is sort of a trial of nature, if you will. It's using genetic risk factors or markers for rheumatoid arthritis to generate a risk score of liability of having rheumatoid arthritis. They used a large cohort of patients with RA and controls without RA. And by using this risk liability or genetic liability, they were able to show that having these genetic risk factors confers a risk for coronary artery disease as well as hemorrhagic stroke. And this is obviously independent of all of these traditional risk factors. They were able to show that none of this genetic liability is not associated with any of the traditional risk factors, but in fact, was associated with higher levels of inflammatory markers such as TNF, CRP, and IL-6, which means that the way rheumatoid arthritis or genetic liability to rheumatoid arthritis mediates its risk, or inflammation mediates the risk of rheumatoid arthritis to cardiovascular events. And if we treat inflammation, we could potentially reduce this cardiovascular risk in RA patients. The next study that I wanted to highlight deals with corticosteroids and how much is too much of these medications. We know that these medications are associated with multiple adverse effects, but sometimes it's just impossible to get patients under control without them. We know that we need to try and minimize the duration and the dose, but how much is too much? So this study, I think it's quite useful for clinicians because it does provide some benchmarks, and it assessed patients with RA from the core Evitas or Corona registry in the US. And within a limited period of time, they evaluated the association between use of people who are just being prescribed corticosteroid for the first time. And they showed that both the duration as well as the dose of prednisone was associated with increased cardiovascular risk. Importantly, that they showed that within a window of 6 months, patients who were on prednisone for more than 80 days or on more than 5 milligrams of prednisone a day, this was already associated with 50% higher risk of developing a major cardiovascular event. So I think these provide quite useful benchmark for rheumatologists and other clinicians that use corticosteroids as sort of a bridging while waiting for DMARDs to kick in and control the disease. Finally, I wanted to mention these EULAR guidelines. These guidelines continue, or the second part of previous guidelines that were published for inflammatory arthritis and recommend how to manage cardiovascular risk in these patients. In these guidelines, they included for the first time diseases such as lupus and antiphospholipid. And these are very interesting, and it's a very detailed document, and I encourage you to read it. I just wanted to highlight this section from the overarching principles of these guidelines, where they really discuss who should be responsible for the management of cardiovascular risk. And these guidelines put the rheumatologist at the center of care, and they should coordinate this effort and work, of course, with cardiologists and family physicians. We were asked to write a commentary on this these EULAR guidelines in Nature Review, and we have slightly different view of who should be responsible. And we believe that delivery of care should be more shared across disciplines and should involve primary care, family physicians, as well as cardiologists, and consider the expertise and knowledge of each of these specialists. What we try to do in our program is share care and transfer knowledge across disciplines, and we believe that by doing that, we will be able to serve better our patients. This symposium is one of these attempts to build bridges across disciplines, and we do hope that we'll be able to continue doing that in the future. So I'll turn it over now to Dr. Akhtari.
Good morning, everyone, and thank you, Dr. Harvey and Dr. Eder, for the opportunity to be here. Continuing on, I'm going to highlight a number of interesting research publications that were published in the cardiology literature over the last year or so. And so the first, I have no disclosures relevant to this talk. The first paper that I want to discuss with you is this publication in JACC, Journal of American College of Cardiology, in 2021, looking at high sensitivity CRP and how that modifies the cardiovascular risk imposed by lipoprotein a. This was a study based off of the multi-ethnic study of atherosclerosis dataset, a large dataset conducted in the US. So just to give you a little bit of background about this, cardiovascular disease remains a leading cause of death and disability globally. And despite the optimal management of traditional cardiovascular risk factors, residual risk of atherosclerosis remains high. And so there's this ongoing search for additional targets of therapy that might help us improve cardiovascular health and outcomes. Lipoprotein a and high sensitivity CRP are both established biomarkers that can facilitate atherosclerotic cardiovascular disease risk stratification in primary prevention. They are both part of the American College of Cardiology 2018 dyslipidemia and 2019 primary prevention guidelines. And as you can see here at the bottom, both elevations of high sensitivity CRP above 2 milligrams per liter and elevated levels of lipoprotein a above 50 milligrams per deciliter can be used as risk enhancers to help better define an individual's overall cardiovascular risk. Just to continue on in terms of background, a recent post hoc analysis of the Accelerate trial, which was a secondary prevention study, found that elevated LPA was only significantly associated with major adverse cardiovascular outcomes when a high sensitivity CRP was concomitantly elevated. But this was not previously studied in the primary prevention setting. So the goal of the study that we're looking at was to try to address this in the primary prevention setting. For those of us who don't use these biomarkers on a daily basis in clinical practice, just some additional background about lipoprotein a. Lipoprotein a is a lipid molecule very similar to LDL, so they look quite similar, with the difference that lipoprotein a has this additional glycoprotein ApoA associated or actually covalently bound to its ApoB moiety. It's a highly atherogenic, pro-inflammatory, pro-thrombotic lipid molecule. It's largely controlled by a single gene locus on LPA on chromosome 6, and it's highly heritable. And the plasma concentrations of lipoprotein a over an individual's lifespan is quite stable. It's not affected by age, sex, inflammation, or lifestyle. Epidemiologic and genetic studies have really found that there is a robust association between lipoprotein a and coronary heart disease, risk of MI, stroke, and also calcific aortic valve stenosis, actually. And so this is sort of suggesting that there's a causal association between LPA and coronary heart disease. So in terms of inflammation, we all now appreciate inflammation as being an emerging target of therapy to potentially reduce residual ASCVD risk. The results from recent large RCTs have really demonstrated improved cardiovascular outcomes with specific anti-inflammatory therapies. We're going to hear about this later on in today's session. And among numerous inflammatory biomarkers, high sensitivity CRP really has the most extensive predictive validation with regards to ASCVD outcomes. And so again, the purpose of this study was to determine whether subclinical inflammation, as assessed by high sensitivity CRP, modifies this LPA-associated cardiovascular risk in a population without coronary artery disease at baseline. So essentially sort of a primary prevention setting. And so unfortunately, I think my slides are not clicking properly, and so I can't show you the slide on the background here. There was, in fact, a significant interaction observed between Lp(a) and high sensitivity CRP. I will explain to you what the slides showed. So what they looked at was time to first event in years. And on the y-axis in all of these figures, we're looking at cumulative incidence of cardiovascular disease. And what they found is that high sensitivity CRP, when it was not elevated, in that setting, there was really no significant risk of cardiovascular disease across any level of lipoprotein little a. However, lipoprotein little a was associated with incident cardiovascular disease when high sensitivity CRP was in fact elevated. So the figure that you can actually see is looking at, again, time on the x-axis and cumulative incidence of cardiovascular disease events. And we're looking at women versus men. And the different lines represent different combinations of LPA and high sensitivity CRP. So the purple line represents non-elevation in both factors. And the light blue represents elevation in LPA as well as high sensitivity CRP. And the red and the black represent elevation in either factor. And what we can appreciate is that in both sexes, compared to those who had neither elevation in LPA nor high sensitivity CRP, the presence of either factor was not significantly associated with an increased risk of cardiovascular events. However, concomitant elevation of LPA and high sensitivity CRP, both in men and women, was significantly associated with higher cardiovascular disease events. And they actually also showed that dual elevation of the LPA and high sensitivity CRP was actually associated with significantly higher all-cause mortality. So very interesting findings from this study. So the take-home message from this is that in the setting of primary prevention, LPA-associated atherosclerotic cardiovascular risk was observed only with concomitant elevation of high sensitivity CRP. The mechanism not clear, but inflammation seems to have this potentiating effect on lipoprotein A risk. And individuals with concomitant presence of LPA and systemic inflammation have a greater ASCVD risk and all-cause mortality and merit closer surveillance and more aggressive ASCVD risk management. The next study I would like to review with you or present to you is a publication in JACC, Cardiovascular Imaging, again in 2021. This was from Dr. DiCarli from Brigham and Women's Hospital and his group in Boston. And what they looked at was they evaluated the prognostic value of impaired coronary vasodilator effect in patients with systemic inflammatory disorders. So again, to give you a little bit of background about this, we know that autoimmune systemic inflammatory diseases are associated with coronary vasomotor dysfunction. This reflects a combination of epicardial atherosclerosis as well as functional abnormalities in the coronary microcirculation. Possible mechanisms for this are that high serum levels of pro-inflammatory cytokines, including IL-6, IL-17, interferon alpha, TNF, perturb the endothelial function and vascular health. But prior to this study, the prognostic significance of this was previously not studied. So the purpose of this study was to evaluate the prognostic value of quantitative myocardial blood flow and myocardial blood flow reserve in patients with systemic inflammatory disorders. This was a retrospective study of patients with rheumatoid arthritis, lupus, and psoriasis. Included in this study were patients who had clinically indicated rest and stress myocardial perfusion PET. Exclusion criteria was presence of LV dysfunction or abnormal myocardial perfusion study. And the myocardial flow reserve was calculated as the ratio of myocardial blood flow at peak stress compared to that at rest. And so the key findings from this study, what they actually looked at was about 200 patients. 80% were female. Mean age was about 65 years of age. 48% had rheumatoid arthritis, 21% lupus, and 32% had psoriasis. Median follow-up was about 7.8 years. They observed 51 deaths and 63 major adverse cardiovascular events. And what they found was so they divided the myocardial flow reserve into tertiles. And what they were able to show is that compared to those that were at the highest tertile, depicted in blue at the top here, those who had the lowest tertile for myocardial blood flow reserve had higher both all-cause mortality as well as cardiovascular event-free survival. And this was significant even after adjusting for age, sex, and pretest clinical risk scores. Unfortunately, again, my other figure is hidden behind this, but it sort of looks similar and shows lower survival as well as lower CV event-free survival for both for those that were at the lower tertile. So the take-home message from this study is that in patients with systemic inflammatory disorders, impaired coronary vasodilator reserve was associated with worse cardiovascular outcomes as well as all-cause mortality. So important findings. The next study I would like to present to you is this publication, again in JACC in 2021. This was a Danish study. And it looked at long-term cardiovascular outcomes in systemic lupus. And for those of us that see these patients regularly in clinical practice, the findings from this study are not at all surprising and is in keeping with what we see clinically. It's a contemporary assessment of this issue. And what's interesting is that they had a very large number of patients that they looked at, and they had matched controls. So this was based off of the Danish administrative registries. They included 3,400 patients with lupus, obviously predominantly female. Mean age was about 44 and a half years of age, median follow-up of 8.5 years. And they compared patients with lupus with no history of cardiovascular disease and matched controls from background population. And they reported on 10-year absolute risk of heart failure, mortality following a diagnosis of heart failure, and other major adverse cardiovascular outcomes. And so what they were able to show is three main findings. So here on the x-axis, we have years after inclusion in the study, and on the y-axis, we have absolute risk of heart failure. Red represents patients who had lupus, and blue is the background population. So clearly, patients with lupus have a significantly elevated risk of having a diagnosis of heart failure. In this part of the graph, we're looking at years after a diagnosis of heart failure was given, or patient had a diagnosis of heart failure. And on the y-axis, we have the absolute risk of all-cause mortality. And we can see again in red that patients who have lupus after a diagnosis of heart failure, they do worse compared to patients with a diagnosis of heart failure without lupus. And the third main finding from this study was that they looked at a number of different major adverse cardiovascular events, and across the board, outcomes or absolute risks are worse for patients with lupus. So incidence of atrial fibrillation, ischemic strokes, myocardial infarction, not surprisingly, venous thromboembolism, also ICD insertion, ventricular arrhythmias, sudden cardiac death, and all-cause mortality, all significantly higher in patients with lupus compared to the background population. So the take-home message from this study is that during long-term follow-up, patients with lupus face a higher risk of heart failure and other adverse cardiovascular outcomes than matched control subjects. And mortality associated with heart failure is greater among patients with lupus compared to patients without lupus who have heart failure. And I just added this slide because the year in review wouldn't be complete without mentioning something about colchicine, but I won't really be going into this at all because we're lucky today to have Dr. Tardif talking to us about the role of colchicine in coronary disease. So I'll leave it at that, and I thank you for your attention.
Thank you, Dr. Eder and Dr. Akhtari. I should have mentioned before we started this session that Dr. Eder is, as I mentioned, our co-director of our program here, both at Women's College Hospital and at the U of T, and in fact holds a Canada Research Chair for her work in inflammatory rheumatic disorders. And Dr. Akhtari runs our primary prevention Cardio-Rheum program and is an expert in anything to do with atherosclerosis in patients with inflammatory rheumatic disorders. So we have just a few minutes up our sleeve. One of the things that really struck me from this update was that we're looking at genetics, we're looking at biologics, targeted therapies. We're still looking at cardiovascular risk associated with prednisone that we've been using for who knows how long, trying to tease out what is the etiology of cardiovascular risk with the steroids. We're looking at novel cardiovascular risk factors, so the Lp(a), and that's fascinating that it's only leading to increased cardiovascular risk when it's associated with the elevated CRP. And then looking at coronary function and the risk of events when it's not actually related to atherosclerosis, but to vasomotor dysfunction. So we're really starting to tease out lots of different components that are leading to cardiovascular risk. And the more we study this area, the more complicated it seems to get, and the more we need to be collaborating with one another in rheumatology, cardiology, probably genetics, our colleagues in advanced imaging, and of course our other colleagues such as in family practice. It's also very depressing to see that lupus continues to confer an increase in cardiovascular risk of all different types, even though it's probably one of the first areas we started to study with respect to cardiovascular risk in the inflammatory disorders. Since we only have time for one or two questions, I just wanted to ask you, Dr. Eder, with the steroids, did they have any thoughts as to why the risk was conferred beyond, if I understood it correctly, beyond the 6 months of treatment with the corticosteroids? Was there some underlying theory for that? Is it related to cardiovascular risk factors or something else?
Yeah, I think it's a little bit artificial to say that beyond this point, right? But we as clinicians like working with cutoffs or absolute levels because it's just easier. But probably the dose, there is a dose response effect, so it's not just if you prescribe someone 6 milligram compared to 5 milligram, it's not that it jumps by 50%. We know that the higher the dose and the higher the duration is worse, but thinking about cutoff, this is just a more, I guess, useful from the point of care, that within this 6 months period, we can, know that if we sort of are, if our patients are using more than this dose or more, and the duration is longer than 80 days, then we probably should be starting to reduce these steroids.
Do they think that's related to the cardiovascular risk factors, the promotion of hypertension and diabetes? Is it still thought to be through that mechanism? Did they comment? Yeah,
so we know from the past that yes, corticosteroids mediate at least some of the cardiovascular risk through the increase of these traditional cardiovascular risk factors, as well as changing the patterns of lipids that are also known to affect cardiovascular risk.
Mm-hmm. Okay, so I'll remind everybody that we do have the chat box for any questions, and Dr. Eder and Dr. Akhtari will be joining us for the panel discussion, which is going to be at 11:30 at the end of our morning session. So thanks again to Dr. Eder and Dr. Akhtari. My next pleasure is to announce our next speaker, Dr. Jean-Claude Tardif, who is going to be speaking today on the use of colchicine for prevention of cardiovascular events. Dr. Tardif's bio is included with the information about our symposium today, but I really just want to highlight some of his many, many achievements. So Dr. Tardif is the director of the Research Centre at the Montreal Heart Institute and Professor of Medicine at University of Montreal. He holds the Canada Research Chair in Personalised Medicine and the University of Montreal Pfizer Endowed Research Chair in Atherosclerosis. He's the Scientific Director of the Montreal Health Innovations Coordinating Centre. His research covers the molecular and genomic aspects of atherosclerosis and related diseases, and involves animal models, mechanistic and observational clinical studies, as well as early clinical trials and large international randomized clinical trials. So research across many different methodologies from bench to bedside. He's won multiple awards during his career, including the Research Achievement Award at the Canadian Cardiovascular Society, Distinguished Lecturer Award of the Canadian Institute for Health Research, amongst others. Because of his accomplishments, he was named a Fellow of the Canadian Academy of Health Sciences and was inducted in the Order of Canada, the highest distinction of our country here. So with that, I'd like to hand over to you, Dr. Tardif, for you to give us our talk today on colchicine and cardiovascular events. Thank you.
Well, thank you so much for the invitation and for organizing this great symposium. I'm going to take the next half hour or so discussing indeed the use of colchicine for prevention of atherothrombotic events. And here are my disclosures. So there is a wealth of data that have been generated over the past several decades, actually, that have shown that inflammation is involved in the initiation, the progression, and the destabilization of atherosclerosis and its plaques. I will not have the time to go through all the details, but clearly it involves a number of cytokines, chemokines, different white blood cell types. But at the end of the day, this has been known, and the important thing now is, can we modify the evolution of atherosclerosis by reducing vascular inflammation? So I'm just going to show you one paper that we've published last year showing the effects of colchicine on atherosclerotic plaque vulnerability. Without going into all the details, we showed that colchicine reduces plaque inflammation, medial fibrosis, deleterious outward vascular remodeling, as well as ex vivo monocyte activation. And there have been a number of studies suggesting that if you reduce inflammation of the vascular wall, that you are going to stabilize plaques. Now, at the end of the day, as clinicians, what we are mostly interested in, and obviously, is seeing whether or not by reducing inflammation in patients with vascular disease that we are going to improve their outcome. So this is a busy slide that we've published a year or two ago in European Heart Journal, just listing a number of clinical trials that have tested anti-inflammatory therapy in cardiovascular disease. I would just like to point out the second line here, the CANTOS trial with the monoclonal antibody to interleukin-1 beta canakinumab that showed that in 10,000 patients with vascular disease, that inhibiting interleukin-1 beta did reduce vascular events in patients with established vascular disease. This was really the first large-scale trial showing this. However, CANTOS is an injectable, quite expensive, and in that study, there was a small but significant increase in the risk of septic shock that was potentially fatal. And so that brings me to the use of colchicine as another powerful anti-inflammatory agent, but this time this agent is obviously orally administered, inexpensive, and has been shown over decades, if not more than a century, to be safe. And so we have conducted a large but simple randomized trial called the COLCUT trial, the Colchicine Cardiovascular Outcomes Trial, which was a study of 4,745 patients randomized within 30 days after myocardial infarction. These patients, as you see on this slide, received all the good drugs that they are expected to receive, including a statin, most often a high dose of a powerful statins, 2 antiplatelet agents because we were in the post-MI setting, as well as other agents, including a RAS inhibitor commonly. These patients were treated according to national guidelines. They underwent percutaneous coronary intervention, PCI, if deemed necessary by the treating physician, and then they were randomized to receive either low-dose colchicine, 0.5 milligrams once daily, or placebo. The primary efficacy endpoint was the composite of cardiovascular death, cardiac arrest, myocardial infarction, stroke, or urgent hospitalization for angina requiring coronary revascularization. Just to give you a feel for the type of patients that were included in COLCUT, you see mean age 61 years, a minority of women, unfortunately, mean body mass index 28, hypertension was present in half of the patients, and diabetes in 20% of the patients. As the 5 last lines of this slide indicate, only a minority of patients had a prior history of cardiovascular disease before their index myocardial infarction that led them to be included in the COLCUT trial. The mean interval between myocardial infarction and randomization into COLCUT was 13 days or 2 weeks. As you see here, the vast majority of patients underwent percutaneous coronary intervention, or PCI, 93% of patients. And standard of care was excellent. Aspirin was used in 99% of patients, a second antiplatelet agent in 98% of patients, a statin in 99% of patients, and a beta blocker in 89% of patients. So whatever numbers and results I'm going to show you, certainly remember that colchicine was combined with a statin in 99% of patients. And so to cut to the chase here is the primary efficacy endpoint result in the overall intent to treat population, or ITT population. And you see that the addition of colchicine to standard of care compared to placebo resulted in a 23% relative risk reduction in favor of colchicine compared to placebo, with a p-value of 0.02. And you see that the Kaplan-Meier curves diverge very early in favor of colchicine. Now with more granularity, well, the first line here that is underlined, you see that the absolute risk reduction was 1.6%. And then the next 5 lines shows you the point estimate for each of the 5 components of the primary endpoint. And they ended up being on the right side of the unity line for all 5 components. So the point estimate for the hazard ratio for CV death was 0.84, resuscitated cardiac arrest 0.83, myocardial infarction 0.91, stroke 0.26, and urgent hospitalization for angina requiring revascularization 0.50. So the effect of colchicine on each of the 5 components resulted in this overall benefit on the primary composite endpoint, but the effect in COLCUT was more marked on stroke and urgent hospitalization for angina requiring revasc than myocardial infarction, but we'll come back to that in a few minutes. We had pre-specified that we would also evaluate the per protocol population of patients without major protocol deviations, and when we did that, the effect or the benefit of colchicine was even more marked, with a 29% relative risk reduction and a p-value of 0.004. And then with more granularity, you see again in the per protocol population, marked effects on each of the 5 components, including here a more marked effect on myocardial infarction. So up to now, I've shown you the typical way that we use to demonstrate the effect of a cardiovascular drug, which is time to first event. But from the patient perspective, from the healthcare system's perspective, the payer's perspective, from the physician's perspective, it is obviously not only the first event that is relevant, but it is really the total burden of events. So now I'm showing you a pre-specified analysis in cold cut, which was the so-called recurrent event analysis, which looks at the total burden of both first and recurrent or subsequent ischemic primary endpoint events. I will spare you the different approaches to evaluate this statistically, and I would just ask you to focus on the red numbers here, which was the pre-specified primary approach to look at recurrent events. And you see that when we did that, colchicine resulted in a 34% reduction in the total burden of events compared to placebo. And quite frankly, I think that this has never been shown with any other agent on top of an aggressive or intensive preventative approach using a high dose of a powerful statin. So turning now to safety and tolerability, perhaps I should remind you that we used a low dose or 0.5 milligram dose of colchicine here, and that was a particular long or extended release formulation of colchicine. So in cold cut, 4,700 patients followed for 2 years. We were actually pleasantly surprised by the safety and tolerability profile of long-term use of colchicine. As you can see here, there was no significant increase even of diarrhea as an adverse event, 9.7% in the colchicine group, 8.9% in the placebo group. The difference was not significant. We did see a small but significant increase in the incidence of nausea in 1.8% of patients in the colchicine group and 1.0% in the placebo group. And then if you look farther down, there was a small but significant increase in the incidence of pneumonia reported as a serious adverse event in 0.9% of patients in the colchicine group and 0.4% in the placebo group. And so while the difference was significant, it was still less than 1%. But there was no increase in the incidence of septic shock, 0.1% in each arm. So the question was at that stage, well, typically when we give cardiovascular drugs, we've seen several drugs having benefit, but you often pay a price. Typically when we give antiplatelet agents or anticoagulants, patients bleed. So the question was here, when you start affecting inflammation and immunity, are you going to pay a price in terms of increased risk of infection? And later on, I'll show you a meta-analysis where we have shown that globally that risk did not exist. But we will come back to that in a minute. So we have also looked at another concept, and you see here underlined TTI. It stands for time to treatment initiation, which is the interval between the occurrence of myocardial infarction and the date on which the patient was included in the trial. So here you see the subgroup of patients recruited within 3 days after myocardial infarction or before hospital discharge following myocardial infarction. The rationale being, well, we know that atherosclerosis is a chronic inflammatory process, and we know that an acute myocardial infarction is an acute exacerbation of that underlying chronic inflammatory process. So the question was, if we start treating patients even earlier with colchicine after myocardial infarction, will the benefit be even larger? And here is this subgroup analysis that we published in the European Heart Journal. And you see that indeed, among the patients who were recruited and included in the study before hospital discharge, the benefit of colchicine was even larger. Here you see a 48% relative risk reduction compared to placebo, in favor, obviously, of colchicine. So we were pretty excited to have reported the results of that large trial, and the results were published in the New England Journal. But that was one large trial in the post-MI setting. We were really excited when a second group of investigators, this time from Australia, came back with the results of the low-dose 2 trial, or low-dose colchicine 2 trial, a year after we published our results, and they too published in the New England Journal of Medicine. You will see that these results, we believe, complement well the results of COLCUT. Again, COLCUT, 4,700 patients recruited after myocardial infarction. Low-dose 2 here, 5,500 patients with stable chronic coronary artery disease, who again were randomized to low-dose colchicine or placebo. And the primary endpoint was the composite of cardiovascular death, myocardial infarction, ischemic stroke, or ischemia-driven coronary revascularization. You see that the type of patients included in low-dose 2 were relatively similar to those of COLCUT, but with a few exceptions. So mean age was a bit higher in low-dose 2, 66 years of age. Hypertension, as was the case in COLCUT, was present in half of the patients of low-dose 2, and diabetes present in 18% of patients, as was the case in low-dose 2, in COLCUT rather. While I told you that patients in low-dose 2 had to be stable, nevertheless, you see that 83% of patients had undergone prior coronary revascularization, and 84% of patients had a prior episode of acute coronary syndrome, all of them more than 6 months before inclusion in low-dose 2. And actually, more than 2/3 of patients had their last acute coronary syndromes more than 2 years before being included in low-dose 2. In terms of concomitant medications, obviously the use of dual antiplatelet therapy was much lower in low-dose 2 than COLCUT, because these patients had chronic coronary artery disease. So only 23% of patients used DAPT, or dual antiplatelet therapy, whereas it was 98% of patients in COLCUT. Statins were used in 94% of patients, and a RAS inhibitor used in more than 70% of patients. The results of low-dose 2 were also strongly positive, as were those of COLCUT. You see here that the addition of colchicine to standard of care compared to placebo resulted in a 31% relative risk reduction with a p-value less than 0.001. And as was the case for COLCUT, you see again that the benefits emerged rapidly in favor of colchicine compared to placebo. That was for the primary endpoint. Turning now to the key secondary endpoint, which is a composite of cardiovascular death, myocardial infarction, or ischemic stroke, a 28% reduction in the risk of the occurrence of this key secondary endpoint with colchicine compared to placebo, with a p-value of 0.007. And then turning to a number of ranked secondary endpoints, I will not go through all of these results. The first line is what I just showed you. Let's just focus on lines number 3 and 5. Line number 3 is the composite of cardiovascular death or myocardial infarction. You see that the hazard ratio is 0.71, so a 29% relative risk reduction with a p-value of 0.01. In line number 5, all fatal or non-fatal myocardial infarction, the hazard ratio is 0.70. So there was a relative risk reduction of 30% in favor of colchicine compared to placebo with a p-value of 0.01. As was the case in Colcut, if you look at line number 7, there was no significant difference in the occurrence of all-cause death. And this was the result of the summation of a trend for a reduced risk of cardiovascular death and a non-significant trend for an increased risk of non-cardiovascular death, as you can see here, but without imbalances in new cancers, infections, pneumonias, or hospitalizations for GI reasons. There was also no evidence of myotoxicity, as was the case in Colcut. We'll come back to that towards the end. So let me just turn now to meta-analyses of all colchicine studies in coronary artery disease. I believe that there are at least 5 published meta-analyses in the last 18 months or so that have all shown the same thing. So I will focus on the one that we have published. I would like to acknowledge that this is the work of one of my young colleagues, Michelle Samuel, and that was published in the Canadian Journal of Cardiology. So again, this is a meta-analysis of all colchicine studies in coronary artery disease, first looking at the primary composite endpoint of cardiovascular death, MI, stroke, and urgent coronary revascularization. And perhaps let's just focus on the overall result in red, where the hazard ratio was 0.68. So that means a 32% relative risk reduction, with the upper bound of the 95% confidence interval being 0.81, meaning the worst case scenario is a 19% benefit of colchicine. Imagine on top of standard of care, and all of that with less than $1 a day. So now the next 4 slides are all going to be in the same format. So I'm going to ask you to just focus on the second line of the title. So that is going to show you the endpoint of interest. And then you can look at the line in red, looking at the point estimate for the effect here of colchicine on myocardial infarction. You see a 38% relative risk reduction in favor of colchicine compared to placebo. The next slide with the same format will be about ischemic stroke, a 62% relative risk reduction in favor of colchicine compared to placebo. And finally, urgent coronary revascularization, a 44% relative risk reduction in favor of colchicine compared to placebo. Turning now to the effect on the composite of cardiovascular death, myocardial infarction, and ischemic stroke, you see a significant 22% relative risk reduction with colchicine compared to placebo, again, on top of excellent standard of care. So a word about mortality in the colchicine studies. The take-home message is that there is a neutral effect on all-cause mortality here in this meta-analysis, a risk ratio of 1.04, so a neutral effect on all-cause mortality. So what we have with colchicine is robust reductions in non-fatal cardiovascular events, namely myocardial infarction, stroke, and urgent coronary revascularization, but a neutral effect on all-cause mortality, which is the result of the summation of a non-significant trend for a reduction in cardiovascular mortality and a not significant trend for an increase in non-cardiovascular mortality, as you see here on this slide. But then when you look at the number of safety outcomes in this meta-analysis, no effect on infections, pneumonias, hospitalization for GI event, or diagnosis of new cancers. And we've reviewed all of that in details in an invited editorial in Circulation 18 months ago. So these large-scale trials, along with these published meta-analyses, probably led to the decision by Health Canada to approve low-dose colchicine for cardiovascular prevention in August 2021. So here are the words of Health Canada. These are not my words. Colchicine extended release is indicated for the reduction of atherothrombotic events in adult patients with existing coronary artery disease, in addition to standard therapies, including LDL cholesterol lowering and antithrombotic drug treatment. The second bullet point is also from Health Canada. Extended release colchicine is contraindicated in patients taking strong PGP inhibitors or strong CYP3A4 inhibitors. The typical example is clarithromycin or Biaxin. Of note, you can use azithromycin with colchicine without a problem. Probably the most important point to remember is that colchicine is contraindicated in patients with severe renal impairment as defined by a GFR less than 30. So if you respect that, low-dose colchicine is very well tolerated. But it is also contraindicated in patients with severe hepatic impairment. And the last bullet point here on this slide is from me. Low-dose colchicine can be administered safely with high-dose statins as per the 10,000 patients followed for more than 2 years in COLCUT and low-dose CO2 indicate. So low-dose colchicine has been approved by Health Canada. It has entered the European guidelines for cardiovascular prevention in August of 2021. It has also entered the South American guidelines in 2021. And I know that it is being discussed as well in the US. There was a nice review paper from Aldo Magione's group from Italy, published in the supplement of the European Heart Journal in 2021, looking at preventative strategies for patients with chronic coronary artery disease, reminding all of us about the importance of non-pharmacological lifestyle changes first, obviously. So that means smoking cessation, a body weight control, a heart-healthy diet, and exercise, and trying to reach a systolic blood pressure less than 130 and an HbA1c less than 6.5%. And then you have a number of pillars of prevention in patients with chronic CAD, obviously aspirin, intensive use of statins, and as indicated with the red arrow, this group of investigators and physicians recommended to consider low-dose colchicine for all patients with chronic coronary artery disease. And this is very similar to a recent position paper that was published in the Canadian Journal of Cardiology by 20 Canadian authors. So in conclusion, let me just read for you the conclusion of another invited editorial that we published in the Journal of the American College of Cardiology. Low-dose colchicine reduces the risk of ischemic cardiovascular events on a background of excellent standard of care, irrespective of whether the patient has had a myocardial infarction or presents with stable coronary artery disease. In light of the positive results from low-dose CO2, COLCUT, and meta-analyses, its good tolerability profile and cost effectiveness at less than $1 a day, inflammation reduction with low-dose colchicine should be considered to treat patients with coronary disease in the absence of severe renal dysfunction. And so all of that is for prevention of atherothrombotic events in patients with established coronary artery disease. And I will leave you with one final thought, which is shown on this slide. How about preventing or trying to prevent atherothrombotic events in patients without known coronary artery disease? And this is the purpose of a study that we will launch 2 months from now, the COLCUT T2D trial, or Colchicine Cardiovascular Outcomes trial in 10,000 patients with type 2 diabetes without known coronary disease. These patients will be randomized to low-dose colchicine or placebo. We have the same primary composite cardiovascular event, but this time we will also be looking in COLCUT T2D at the effect of colchicine on cognitive impairment and dementia because of the wealth of data that has linked inflammation with dementia. We will also be looking at other non-cardiovascular related events. These 10,000 patients will be followed for approximately 4 years. And so I believe that we have shown that low-dose colchicine robustly reduces non-fatal events in patients with established cardiovascular disease. And the next frontier will be primary prevention. I thank you for your attention.
Thank you, Dr. Tardif, for a wonderful talk. We have several questions in the chat, but I can't resist it's actually pertinent to one of the questions here, sort of asking, what about patients with inflammatory rheumatic disorders? It's, the obvious question was primary prevention, and you're doing it in type 2 diabetes. We actually know that patients with rheumatoid arthritis, for example, have the same increase in cardiovascular risk as patients with diabetes. So is there any evidence or any small studies? We do use colchicine in some patients with pericarditis. I don't know if there's anything that's people have been able to extrapolate from other studies, but this is one of the questions in the chat, and certainly is just seeing the diabetes and knowing the relative risk of our cohorts of patients. Do you have any thoughts?
Yeah, that's a great question. First of all, I absolutely agree with you, Dr. Harvey, that patients with inflammatory rheumatic disease clearly are at much higher risk than for cardiovascular disease than healthy controls. And as you said, the risk is probably similar to what we unfortunately we see with diabetic patients. So actually, what I did not say in the last slide is that we are targeting patients with diabetes and at least one additional risk factor. And having rheumatoid arthritis is actually will be an additional risk factor. So we'll have some patients with rheumatic disease. To get directly to your point, the data that I am aware of, there is some data in patients with gout. I mean, these are not randomized trials, but I've suggested that patients with gout that were treated with colchicine had a reduced risk of cardiovascular events than those not treated with colchicine. But I guess this should be taken with a grain of salt because this obviously was not a randomized trial.
Mm-hmm. So the other thing about these studies that I can't help noticing as someone who I got into this whole area of cardio-rheum because of my work in women and heart disease. And we know that a lot of the inflammatory rheumatic and autoimmune disorders disproportionately affect women. And in these clinical trials, unfortunately, we're still seeing predominantly males being studied. So I guess two comments there. One is that if we were to look at patients with rheumatoid, for example, or lupus, we would be having much larger percentage of participants would be women. But do you have any, are there any differences, sex differences in the responsiveness that was identified?
Yeah, what a great question. First of all, I'm really excited with the colchicine data that we and others have generated. I'm less excited about the poor result in terms of number of patients, women we had in these trials. And I think your point is well taken. So we had 20% of patients who were women, both in COLCUT and low-dose CO2, and that's not enough. what I can tell you is, well, two things. COCA T2D is funded by CIHR, and we obviously are putting now a lot of emphasis on trying to be better at recruiting patients, women patients in this study. What we've added is that we've added patient partners in all of our trials. So our patient partners now are part of the steering committee, the data safety monitoring board, strategies for recruiting more women. So that's one. So I cannot guarantee that we will be successful, but we are working very hard at making sure that we'll have at least 40% of patients that will be women. As far as the question of, is the effect as good in women as it is in men, that is colchicine in patients with cardiovascular disease, I unfortunately cannot answer that because we did not have enough women in that in those studies. And I agree with you. We need to do much better, and any advice would be welcome.
Well, you know, working in this area for a couple of decades, we are making progress, but it does, unfortunately, we do know that it's slow, and we really need to be implementing all of these different mechanisms into our research, and that's from bench to bedside. So I don't have, you know, nobody has the magic answer, but clearly you're looking at a lot of different mechanisms people have been using. I'd like to just move to a couple of other comments and questions. There was an interesting comment from Dr. Batty, who is actually a family practitioner here at Women's College Hospital. She was making the observation about CRP and the relationship to major depressive disorders. And we know depression is a cardiovascular risk factor, particularly prevalent in women. And I note that you mentioned you'll be looking at cognitive function in your upcoming clinical trial. So just wondering, will you have an opportunity to be looking at any of the other risk factors like depression?
Oh, that's a great question. Yes. So first of all, not only is there data linking inflammation with cognitive dysfunction and dementia, but you're quite right. There's this whole field of research linking obesity, visceral obesity, systemic inflammation, and depression. So what, you know, obviously I tried to limit my comments, but yes, we will be doing serial neuro psychological assessments, and we will also be looking at depression serially. One thing I did not say, and again, probably need to be taken with a grain of salt, but there was a post-hoc analysis from LODOCO2. So it's post-hoc, but it's 5,500 patients followed for 2 years. There was a large reduction in the incidence of dementia with colchicine in LODOCO2, large. So we'll have to see, you know, this was post-hoc, but they saw a 60% reduction in dementia. So I guess we in Canada will be the first ones doing that, looking at that prospectively. Yes, it's going to take 4 to 5 years, but we will be looking very carefully at cognition and depression.
I wonder how much that is related to the direct anti-inflammatory versus you've shown reduction in ischemic stroke. I wonder if there's reduction in ischemic brain injury as well in these patients. I'm
not sure. And we'll try to figure that out. There'll be an imaging sub-study in COCA2, and we'll try to understand and to address that question.
Soon enough for us, hopefully, as we get into the older age group, our cohorts. It would be great to have an effective agent for reduction of cognitive dysfunction.
Yes.
Now we've got a couple of questions here specifically from family doctors, and I would point out again that we do have the panel discussion, so we'll be able to address some of the other questions that are coming in. There was a question as to whether or not family doctors can initiate treatment with colchicine. And a practical question, what dose and how should this be monitored?
Oh, yeah, so absolutely. I hope that this is going to be prescribed by family physicians. I mean, I think all family physicians have used colchicine for gout, and probably a lot of them have used it for acute pericarditis. Colchicine is, you know, first-line therapy for acute pericarditis. It's a great drug. Anyone that's used it for gout, I mean, you see, within a couple of pills being administered, you see the inflammatory signs decreasing. So yes, family physicians should use it. I would recommend to use a low dose of colchicine. You have two ways of doing this. You have the standard generic colchicine, which in Canada is in a 0.6 formulation. It's 26 cents a day in Quebec, at least. And then you have a new formulation, the one we used in Colcut, which is called Myinfla, Myeinfla, Myinfla, which is an extended release formulation, and that's 50 cents a day, and that's 0.5 milligrams a day. So the way I use it a lot. When I'm not after my cardiac infarction, I explain to patients, there's some risk that they might have GI side effects. So what I do, I tell them, we're not in a hurry, so this is just me saying this. I tell them for the first few weeks to take colchicine every other day, and if they tolerate it well, then they should take Myinfla 0.5 milligrams once daily. So that's how I practice. And then the one thing that one need to be careful about is severe renal dysfunction. I don't use it in patients that have a GFR less than 30. Other than that, there were these old stories about risk of combining colchicine and statins. This is not true. There have been case reports, but one can use colchicine with high-dose statins without problems.
And for the audience here, can you explain to them what the issue is with significant renal impairment?
The risk being, if you use colchicine in patients with severe renal dysfunction, there's a risk of accumulation of colchicine. And so while only 20 to 25% of the excretion of colchicine is through the kidney, where the problems have occurred is really when patients have had severe renal dysfunction and were taking another drug. And then the risk can be severe toxicity, GI-related toxicity, blood-related toxicities, but this does not occur when you're careful with this drug if you don't use it in patients without severe renal dysfunction.
And on dosing, there was a specific question about whether a dose lower than 0.5 or 0.6, depending on which formulation you're using, whether you anticipate that would be effective.
I'm not a nephrologist, but so I gave you the conservative cardiologist ignorant view. I've given talks about colchicine where there were indeed lots of nephrologists, and so I will just say what they told me they use. I would not, but they, as expert nephrologists, sometimes use colchicine in patients, for example, with gout, even in undergoing dialysis. They use colchicine 0.25 or 0.3 every other day. But as a cardiologist, I would not be comfortable making that recommendation. Mm-hmm. So I focus on the vast majority of my patients without severe renal dysfunction.
Mm-hmm. I like the idea of starting alternate days. It always helps with tolerability and adherence.
But Dr. Harvey, just before closing, because I know you'll have to keep time, but in a Cardio-Rheumatology Symposium, I haven't spoken about familial Mediterranean fever, but I mean, I've been careful saying low dose and no renal dysfunction. I mean, I know this community knows FMF a lot more than I do. And these patients with FMF take colchicine for life, starting in adolescence, at dosages somewhere between 1.2 and 2.4 milligrams per day. And so, and they don't stop it during pregnancy. They don't stop it. So I've taken a conservative position, but one should be aware of these, data with familial Mediterranean fever.
Mm-hmm. Well, that's a good point to end on. We've got other comments and questions coming into the chat. It's generated a lot of interest, and I think the more we talk about it, the more people will have questions and observations, particularly in our patient cohorts. So we look forward to the panel discussion, which is going to be at 11:30. But thank you for a wonderful, thought-provoking, and a talk about that's practice changing. So very much appreciate that. So everybody continue to put your questions in the chat. We'll be welcoming Dr. Tardif back to the panel discussion at 11:30. This is just the opportunity for 15 minutes for everyone to go off and look at their emails and do anything else that they might want to do. And we are going to reconvene at 11:20. So thank you very much, everybody, for your attendance so far, and we're looking forward to the next few sessions. Welcome back, everybody. We're going to continue the morning session, and it is my pleasure to introduce Dr. Charlene Compher. Dr. Compher is the Shearer Chair of Healthy Community Practices and Professor of Nutrition Science at the University of Pennsylvania School of Nursing. Dr. Compher is an internationally renowned nutrition support clinician who has led a project titled Global Leadership Initiative on Malnutrition, an effort to standardize the diagnosis and description of malnutrition in adult patients in clinical settings. Her research interests include evaluation of the impact of food patterns on clinical outcomes, including in inflammatory bowel disease exacerbations and pregnancy complications. I know we have a lot of people in the audience today who are interested in the role of nutrition in health and disease. And the talk that Dr. Compher will be delivering today is entitled Inflammation and Malnutrition, and how to identify malnutrition in adult ambulatory clinic patients. So my pleasure to hand over to you, Dr. Compher.
Thank you so much. It's truly my pleasure to be with you today, and I look forward to learning from others in this presentation. I have no competing interest relevant to the presentation. Did we lose the slides? Okay, so just a few to give you a sense of where we're going with this. At the end of the presentation, you will be able to identify the impact of diet and foods on the process of inflammation, articulate the importance of food patterns overall, rather than just individual foods on cardiovascular and metabolic diseases, and describe links between disease-related inflammation and malnutrition, and the current thought about how to diagnose malnutrition in clinic patients. So this will have two basic parts to the talk. The first is focused on diet in cardiovascular, rheumatoid arthritis, and psoriatic arthritis, what we know, and diet and inflammation in general, and then we'll segue to disease-related malnutrition. Psoriatic arthritis, we know, is associated with cardiovascular disease. This has been established very eloquently by people who, some of whom are here. We know that there's a greater incidence and prevalence than the general population. The same comorbid conditions are associated with both, and the cardiometabolic comorbidities in psoriatic arthritis are associated with more severe disease and lower therapeutic response. So what is it about diet? What I'm showing you here is the Healthy Eating Index, which is an overall food pattern designed to meet your nutritional requirements. It gives us a sense of the nutrient density. You hear about nutrient dense versus energy dense diets. So this approach is focused on servings of food per 1,000 calories, or a ratio of unsaturated to saturated fatty acids, etc. So it's giving us a sense of how do we focus on foods to get the nutrients we need and the health outcomes that we desire. In the US, this score goes from 0 to 100. In the US, the mean score is around 50, 55, but it varies depending on age. And this approach is also used in many other countries of the world. Excuse me. Just to give you a sense that this approach is important, it's associated with lower all-cause mortality. In this meta-analysis, you can see the reduction in mortality is about 12%. There is a second diet approach that's popular in the US called the diet approach to stop hypertension. And it basically is focused very similarly to the Healthy Eating Index, in that fruits and vegetables are the foods at the bottom of the pyramid you should eat more of, whole grains, dairy to get enough calcium, but fish and seafood over other types of protein, and then nuts and seeds. So sweets very sparingly, and oils just below that. This approach has a strong history of research. The second approach is the Mediterranean diet, which I'm sure you've all heard about. And it is based on diet that was common in Greece and Italy in the mid-1960s, when their cardiovascular disease incidence was the lowest. It focuses once again on whole grains and oils, vegetables and fruits as being more desirable, nuts, legumes and seeds. And then it puts fish, poultry, eggs at lower frequency rate, and dairy also low. Alcohol in moderation, and this is, you're going to see that there's similarity in the food groups that are part of the Healthy Eating Index, and also part of DASH, and also part of Mediterranean. So it's really a lot of overlap, a common scheme. All three of these patterns are associated with lower mortality, both all-cause mortality in the top graph, cardiovascular disease mortality, and cancer. So the commonest diseases in developed countries today are associated with better outcomes when any of these dietary approaches are employed. The Mediterranean diet, in this slide, the upper part shows you people who have a stronger Mediterranean diet pattern have better cardiovascular risk markers, including weight and BMI, but also lipid profile, etc. And the ones that go to the other side of this forest plot are actually recurrence remission of metabolic syndrome. These are positive things, and anti-inflammatory biomarkers. On the other hand, the Mediterranean diet is also associated with lower mortality, lower diabetes, and beneficial outcomes in general. So there's a substantial amount of data linking these diet patterns to improve cardiovascular health. The American Heart Association has established dietary goals that are largely based on the DASH diet pattern. These are the same food groups as the Healthy Eating Index, as Mediterranean, as DASH. The DASH favors a low sodium intake and lower saturated fat. And these are used as educational tools for patients with cardiovascular disease. Now, you hear a lot about plant-based diets. I'm here to tell you today that there are healthy and unhealthy plant-based diets. If you can make out where the blue box is on this slide, these are examples of healthy plant-based foods, and it's whole grains, fruits and vegetables, nuts, legumes, oils, tea and coffee. And then there are unhealthy plant-based foods, including fruit juices, because they are so concentrated with sugar, refined grains, etc., and sugar-sweetened beverages. Now, these data are from Harvard and the Nurses' Health Study and the Physicians' Health Study. And what they did was compute healthy plant-based diet scores. And what I hope you can appreciate, although this slide is hard to read, is that healthy plant-based diets are significantly associated with lower coronary heart disease rates. On the other hand, unhealthy plant-based diets are associated with increased rates of coronary heart disease, even in the second decile. So it's almost having any of those unhealthy plant-based foods is associated with increased cardiovascular risk. Another approach to describing this phenomenon is the Diet Inflammatory Index. This is a score that was derived from a deep literature search associating macronutrients, intake of micronutrients, vitamins and minerals, with inflammatory parameters. It includes 45 different micronutrients, and you score it by subtracting the intake in an individual from a standard global mean intake level and divided by the standard deviation. So you're basically generating a Z-score for 45 different micronutrients. You need to have 24-hour recall information at least to have the levels of intake of these micronutrients, and you probably won't have all of them. The overall score is the sum of the individual item scores, and it can be as low as -9, which is heavily anti-inflammatory, or as high as +8 in the pro-inflammatory direction. The Diet Inflammatory Index is associated with cardiovascular mortality, but it's not quite statistically significant. It is associated with a less inflammatory diet is associated with lower prevalence of metabolic syndrome. And we used the Diet Inflammatory Index in a project with children with Crohn's disease, and showed that a more anti-inflammatory diet score was associated with greater intake of whole grains, dairy foods, and with a higher healthy eating index score, and it's with less intake of saturated fat, added sugars, and proteins. And this is important because whenever we deal with diet in individuals, we're talking about food. We can't, if we try to focus on the individual nutrients that the food provides, that's a recipe to go out and buy dozens of supplements. it's much, much better to focus on what's in the food. There much less is known about diet and rheumatoid and psoriatic arthritis. But in terms of rheumatoid arthritis, this is a schema that's been proposed based on the Mediterranean diet pyramid of there are the foods that are on the lower levels of the pyramid, the ones you should eat more of, namely fruits and vegetables, whole grains, are associated with potentially with an anti-inflammatory effect. And the mechanisms are given here, which has a beneficial effect on joint health, on weight control, and these schemas also bring the microbiota into the conversation. When we think about fruits and vegetables and plant foods that are on the bottom of the pyramid, it's important that we recognize that while we look at those foods as providing vitamins and minerals for us, for the microbiota, there are many, many more plant compounds that they may be responding to. So this is an area of current, really interesting research. On the other hand, these same nutrients reduce the intake of trans fats, of nitrates, of TMAO, which is a cardiovascular toxin that comes from metabolizing fish, but also meat, given the right microbiota. At any rate, these result in a pro-inflammatory effect. They're associated with obesity and can be with a gut dysbiosis, an abnormal gut microbiota. There is a little bit of information about beverages and rheumatoid arthritis. And this is a recent paper showing the effects of tea on at a molecular level on the compounds in tea, epigalic catechin 3 gallate, on inflammation. And basically that compound has an anti-inflammatory effect, reducing levels of TNF alpha. On the other hand, wine in moderation blocks the pro-inflammatory effects that are otherwise seen. So both of these foods are viewed as having some benefit with rheumatoid arthritis. I could find much less information about psoriatic arthritis, but weight loss alone of greater than 5% was associated with increased odds of minimal disease activity, which is has got to be a really important finding. So if you back out to how do we achieve weight loss, certainly for people who are having a low quality diet, eating more fruits and vegetables, more whole grains, less processed foods, is more likely to produce weight loss and satiety at the same time. So I hope I've shown you that the healthy diet is clearly associated with better outcomes, whether we define it in terms of the Healthy Eating Index, the DASH approach, the Mediterranean diet. Mortality is reduced by all of them when people are adherent to those healthier platforms. And it's also associated with better biomarkers of risk. And this is important for us as clinicians because we would like to be able to give our patients feedback at midpoints during their care. So if we can affect the biomarkers, that's one way to give them feedback. And we can't get away from the power of weight loss to these to this disease burden. So what you may be less familiar with, but what I live with and have for the past 15 years or so, is disease-related malnutrition. This is a complex syndrome that results from inadequate intake of nutrients by diet that basically are not adequate to fulfill the physiological requirement. This figure is from a recent review, and it's looking at the situation of aging. But if we all see people who we believe are 20 years younger than their stated age, and they have lower chronic disease burden. But when they have chronic disease, they are more likely to have insulin resistance, loss of appetite, fatigue, be hospitalized, be immobilized. They lose muscle mass and strength, and then they become sarcopenic and malnourished. Alternatively, patients who are in acute clinical situations can have disease-related reduced appetite. Cancer patients actively going through chemotherapy, for example, or someone who's sustained a trauma. Both of those conditions can result in disease-related malnutrition. This is 10 years ago, but 2 years before that, together with a group of international nutrition support experts, we first described this disease-related malnutrition concept. And it was picked up in 2012 by professional dietitians in the US. The concept is that you first identify nutrition risk. In hospitals today in the US, and I suspect in Canada also, it's required that we assess nutrition risk at hospital admission or within 2 days. We determine whether inflammation is present largely based on the clinical condition. And then we can classify, we can evaluate malnutrition and understand whether, how we might describe it. So if there is no inflammation, then it's really more starvation-related malnutrition. The best modern example I can think of is anorexia nervosa. If the inflammation is mild to moderate, then this might be chronic disease-related malnutrition. This would be the rheumatoid arthritis, the sarcopenic obesity, for example. But if there is an acute inflammatory response, say a bloodstream infection, then that's acute disease or injury-related malnutrition. So nutrition screening is how we identify who is malnourished or at risk for malnutrition. It has to be simple and to be easy to conduct. And nutrition assessment is a deeper exploration of the same variables as well as physical exam for malnutrition, lab values, history, etc. This is the most commonly used malnutrition screening tool globally. It's validated. It was designed in Australia. And it's asked 2 questions. Have you lost weight without trying? If yes, how much weight? And have you been eating poorly? And there are a lot of data around this, but the one item I'm showing you here is that identifying malnutrition risk with this tool is associated with significantly longer hospital stay, which is an outcome that's important to the health system. Then in 2018, after 2 more years of deliberation with global leaders, we launched the Global Leadership Initiative on Malnutrition, or GLIM. Our goal with this was to develop standardized language, a sort of a minimum data set that busy physicians in practice could use to identify malnutrition and then consult the nutrition experts. We wanted people in clinics who felt that they didn't have the nutrition training to be able to do a deep dive or to spend 45 minutes or so doing a deep nutrition assessment. So we focus on phenotypic and etiologic criteria. Phenotypically, we need to see non-volitional weight loss. Our European colleagues particularly like low body mass index. In the US, this is rarely helpful, but reduced muscle mass certainly is. And then etiologic, you need to understand why this is happening. Is it because of reduced food intake, or maybe short bowel syndrome, inability to gain the nutrients you need from the food you eat? Or is it the disease burden and inflammation that's causing this? So you need to meet one criteria for etiology and one for the phenotypic. And then we determine the severity. And the severity is based on the phenotypic criteria. Moderate malnutrition is 5 to 10% weight loss within 6 months, or 10 to 20% if it's longer than 6 months. And then severe is more weight loss in the same time frames. The low BMIs are less than 20 if you're under age 70, less than 22 if you're over 70. And we have even lower BMI criteria for our Asian colleagues. And muscle mass, we prefer to have people measure by bioimpedance analysis or DEXA, but physical exam looking for muscle wasting is also completely acceptable. We wanted to be sure that colleagues around the world who have an established program, such as using the subjective global assessment is very common in Canada, would be able to feel comfortable with this framework. But to the degree that we don't use the same language, it's more confusing for the rest of the world to understand what is this disease-related malnutrition. And it's also much harder for the World Health Organization to have the right ICD codes. And it's also harder for patients to understand. But our end goal of this is to be able to compare data better across populations. These are some data from the US hospital inpatient survey showing the rates of malnutrition that physicians code for at the time of discharge. And protein calorie malnutrition was the most common. And if you look on the right, this is 30-day mortality. Any malnutrition diagnosis had 23% readmissions. And if there was no malnutrition, it was only 15%. So that's a significant difference. If you look at the protein calorie malnutrition, which is 24.4%, it's right up there with cachexia and second maybe to post-surgical malabsorption. This is all-cause 30-day readmissions. And you can see that the rates don't differ by age or by rural versus urban, by economic status. It's disease related. It's not related to those other environmental factors. And the hospital costs are also greater. In the US, $25,800 more per admission, when the average cost is $13,000. So that's a significant cost to the health system overall of this condition. And then we have length of stay. So I'm not going to belabor these, but just to say there are significant data showing that this is an issue we need to pay attention to, and that we hope to be able to improve the health of our patients and also the challenges to the hospital system. These are some data from a large sample in my hospital, and the mortality was significantly higher, 1.5-fold higher in those who were malnourished, and the readmissions were also 2-fold higher. Length of stay was longer. So it's not just those other hospitals, it's where you live, and it's something we need to deal with. So what can we do about this? If we identify malnutrition, is there anything we can do? There are a number of studies now showing that if you either adjust the hospital meals, if a dietitian meets with a patient and gets the food they want, or if they get oral nutrition supplements, the cans of formula or the little milkshakes, in fact, you can see shorter length of stay, lower readmissions, lower 90-day mortality. These are really significant outcomes from a fairly simple intervention. We know, though, that inflammation is playing a big role here. This figure may be a little bit hard for you to see. These are patients in the intensive care unit, and the inflammation was judged by C-reactive protein levels. So overall, the ones with, they had nutrition intervention, which was adjusting their intake or giving supplements. Some had enteral feedings, significantly reduced time to mortality, time to death. So the intervention short was better. You didn't die as quickly, even though you were seriously ill. And if they had low inflammation, this was particularly true. Moderate inflammation, it was also true. But once you got to high levels of inflammation, as you might with an acute trauma, there was a less significant benefit in terms of mortality. So just to summarize this last segment, disease-related malnutrition is very common. We need to diagnose it and treat it so that we can improve clinical outcomes. And if we don't do this, we can have more undesirable outcomes for the patient and the health system. Thank you.
Thank you, Dr. Very interesting, and we really do not pay enough attention to nutrition, I don't think, in any of our patients, let alone the very vulnerable patients that we're all interested in with significant inflammation. I was pleased to see that wine, tea, and coffee were included as healthy plant foods. I'm sure I'm not the only one that's taken note of that. And I'm also just wondering, with the evolution of our diet in Western culture, is there another term beyond malnutrition for what we're actually doing with our diets? Like, it's sort of like it's dysnutrition or something, where we're eating so many processed, manufactured artificial foods. I'm wondering if we should actually have another term beyond malnutrition.
That's a very good point. We know that people who eat ultra-processed foods, whether they're doing it because they're only having plant-based foods, the ultra-processed foods are unhealthy plant-based foods. If you're eating them in your regular diet, then you're getting more saturated fat, sugar, more salt than you would if you ate the equivalent. If you think about eating a piece of broiled fish versus a fish stick, there's no comparison in terms of the beneficial nutrients that you're missing and the unhealthy nutrients that you're getting. So there is a campaign going to reduce intake of what we call ultra-processed foods, the ones that when you look at the food, you can't even see where the food came from, that maybe there's not any food left in it. It's all chemicals. And if you can read the label on the package you're eating, it's ultra-processed food. Apples don't come with a label.
So there's a label that says ultra-processed?
If it has a label, the chemical analysis has been analyzed, and usually they are treated in some way to prevent them from spoiling, so they have a longer shelf life in the store. Those are ultra-processed.
Wow, it's extraordinary what we're putting into our bodies. We have questions coming in, and we do have the panel discussion shortly, but there's just one that's relevant to my comment about the teas. We hear a lot about green tea being anti-inflammatory versus black tea, and also the question is, what about herbal teas, and does caffeine play a role here?
That's a great question, and the answer is we are not sure yet. We have a lot more data, honestly, on black tea than we do green tea. But today we are able to distinguish which type of tea using biological fluids like plasma or urine samples. So before metabolomics, we had a lot of difficulty identifying for sure what type of tea someone had. Now, in a research platform, we should be able to distinguish the members of the group that had green tea primarily versus those who were black tea. And green tea also has caffeine. But the chemicals that were in that slide are not the caffeine components.
Okay. So other questions are coming in. I'm going to save them for the panel discussion. And thank you again for a very interesting and thought-provoking lecture. And we'll welcome you back shortly at 11:30 or thereabouts.
Okay, thank you.
And we're going to move on to quite a different topic for our next speaker. I'm going to move now to the talk that's to be delivered by Dr. Buch. Dr. Buch is Professor of Rheumatology and Director of Experimental Medicine, Centre for Musculoskeletal Research at the University of Manchester, and NIHR Manchester Biomedical Research Centre. Dr. Buch is also Visiting Professor of Rheumatology at the University of Leeds. She directs a broad research portfolio in personalised therapeutics in rheumatoid arthritis and difficult to treat and refractory rheumatoid, systemic sclerosis, and cardiovascular pathology in immune-mediated inflammatory diseases. She's current chair of the NIHR versus Arthritis UK Musculoskeletal Translational Research Collaboration. That's a bit of a mouthful. She's a member of the NIHR British Heart Foundation Cardiovascular Partnership and lead of the National Cardio-IMID, that's the Cardiovascular Disease in IMID, UK network. Dr. Buch has informed multiple European, particularly the EULAR management guidelines in rheumatoid arthritis and the British guidelines in systemic sclerosis. And Dr. Buch is going to be speaking to us today about scleroderma and cardiovascular disease. And so with that, I'm going to hand over to you, Dr. Buch.
Apologies, you should be able to hear me now. Thank you for that really kind introduction, and sorry for all those acronyms, didn't know they were going to be read out, but it's a real pleasure to be speaking at this meeting. It's a wonderful, I think, event and initiative, and I'm really pleased to be joining it this year. So as mentioned, this talk is going to have quite a different flavour, and also quite a different flavour in terms of the specific immune-mediated disease of interest, so Scleroderma. I have no disclosure for this talk. So just to take you through, I'll give a bit of a background about systemic sclerosis, generally about the nature of cardiovascular involvement and what we understand in terms of the risk profile or patients particularly at risk of cardiovascular heart involvement. Focus quite a bit on how we diagnose, the role of imaging and prognostication of primary heart involvement, and then finish on management with a particular focus on the role of immunosuppression with some closing remarks. So this is really to illustrate, in a sense, the complexity of systemic sclerosis. I mean, we often hear when we talk about cardiovascular disease in the context of atherosclerotic heart disease and inflammatory diseases like rheumatoid arthritis, psoriatic arthritis, etc. Scleroderma or systemic sclerosis, it's a rare disease compared to rheumatoid, which is common. It can occur at any age between 20 to the elderly, but typically between 40 to 50. And like all our autoimmune diseases, there's a female preponderance. It's typified by three processes, this triad that I've illustrated at the top right here of microvascular pathology, autoantibody activation and inflammation, and subsequent scarring and fibrosis. And a typical first feature of scleroderma is Raynaud's phenomenon. So the peripheral vasculopathy that we see of the color changes in the cold, essentially, but that's whereas in young women, often primary Raynaud's, that's normal. It's a normal exaggerated response to the cold. In autoimmune diseases like scleroderma, that's with the underlying microvascular pathology at play. And so there's various levels of skin thickening, and that's just illustrated here. And this fibrosis and scarring and the vasculopathy can affect not just the skin, but internal organs. And I've illustrated here with lung disease, pulmonary vasculopathy, cardiac involvement, the focus of today, with renal involvement as well. And I'll come on to the type of treatments that are employed, but often not just in relation to cardiovascular involvement, but because of these triad of processes, vasodilatory agents, ACE inhibition, and other mechanisms to improve blood flow and perfusion are employed in the management of scleroderma. So in contrast, I suppose, to diseases like rheumatoid arthritis, where there's been a huge transformation really in how we've understood the underlying pathophysiology and the molecular basis of disease, and that's led to significant targeted therapies. Scleroderma has been a much more complex disease really to make progress in. But this cartoon, this slide is really to illustrate that those three processes that I mentioned before of vascular pathology and endothelial activation, the inflammation process and fibrosis, has led to a better delineation of the molecular pathways, particularly of those of fibrosis, and that is leading to emergent therapies that are being tested. The clinical manifestations are therefore varied, and this is just an illustration of what I've already mentioned, so I won't focus on this any further. But when it comes to heart involvement, of all those different involvements right now in our scleroderma population, pulmonary involvement, so interstitial lung disease and pulmonary hypertension are the major cause of morbidity and mortality, but after that, heart involvement constitutes a major burden. So there's various studies that have indicated approximately a quarter of scleroderma-related fatalities are secondary to cardiac causes. These data here on this slide are from a large USTAR, so European multi-center a resource and epidemiological study. And I'll come on to in a minute in terms of the manifestations of scleroderma-related heart involvement, but essentially when clinically evident, this really does portend a specifically poor prognosis. So really there's been a lot of effort, and the work in scleroderma cardiac involvement has emerged only recently over the last 5 or so years as renal pathology and involvement's been tackled, and as we've made some progress in lung involvement and now recognize the importance of also tackling heart involvement. What I've shown on the left is really depicts outcome from a recent task force and consensus definition on how we should be identifying patients with scleroderma heart involvement. And the purpose of this is really to say that whilst atherosclerotic heart disease is a focus across immune-mediated diseases, in scleroderma, it really is primary myocardial involvement that typifies scleroderma heart involvement. And that contrasts it perhaps with some of the other immune-mediated diseases we come across and we discuss. And the myocardial pathology is really underpinned by the processes that I've already mentioned before, the vasculopathic changes, the vasoreactivity, and cardiomyocyte damage and fibrosis. And so you see on the right a culmination of essentially the kinds of manifestations our patients have. And so it is, whilst we often focus on primary heart involvement, the reality is obviously our patients may have traditional cardiovascular risk factors, as we've already heard about, that lead to coronary artery disease with evidence of systemic inflammation, although the level of inflammation isn't necessarily the same as what we see in diseases like rheumatoid. But we see in our patients pericardial involvement, and particularly this myocardial involvement with arrhythmogenic disturbance. Sudden death is clearly a relevant factor in our patients with scleroderma, with varying degrees of cardiac dysfunction. And it's particularly diastolic dysfunction that's been well documented in patients with scleroderma, going back to this vasculopathic process, microvascular disease that I mentioned earlier. So this is more just to set the scene a little bit, that our patients therefore with scleroderma have skin involvement and may have other internal organ involvement, and the timing and the incidence often is contemporaneous. So often rapid skin involvement is associated with a risk for major organ involvement like lung and heart, and often these can go hand in hand. But this slide is more to illustrate that that may not be the case. So if we start talking, and later on we'll mention more about treatment approaches and even immunosuppression, this may not coincide when patients have other kinds of organ involvement. And so this just adds a bit more to the complexity of the disease. We've been learning more about the profile of patients that put patients at risk of cardiac involvement. And this is from a Royal Free study that I've changed the data on the left into a cartoon, in a sense, not to go into the detail, but it's more to say that certain autoantibody types associated with scleroderma, so the rheumatologist amongst you will be familiar with the SCL70 topoisomerase, that particularly in RNP antibodies, and the diffuse phenotype is associated with cardiac involvement, just like lung and renal involvement as well. But we know that patients that have peripheral myositis also often may have at least subclinical cardiac involvement, but there are various factors like male gender, short disease duration, other markers of severity and activity of disease that identify patients who are at particular risk of heart involvement. This is a study from, I'm sorry, I haven't got the reference here. It's from the Johns Hopkins group that looked at diastolic dysfunction. This is a recent study just published this year to identify a bit more about the risk factors for diastolic dysfunction and the impact on mortality. So the definition was based on various echo parameters. It was a very large study. The Johns Hopkins unit has a very large cohort. So this was 800 patients that had had 2D echo, and it was, the patients were divided into either having normal diastolic dysfunction, intermediate, or diastolic dysfunction. And the comparisons that I'll come on to later on the right were between normal and those with diastolic dysfunction. The table below just shows you, in terms of a univariable analysis and the multivariable, the factors associated with diastolic dysfunction, particularly as maybe expectedly obesity comes in there in the multivariate analysis, and of course age. If you look on the right, there was then an analysis, a Kaplan-Meier done to look at 5 and 10 year survival in groups divided on whether they had normal diastolic function or diastolic dysfunction. Sorry, the abbreviation there is a bit confusing. Essentially, you can see that patients with scleroderma with diastolic dysfunction had lower 5 and 10 year survivals of 40 and 30% respectively. And in further multivariable analysis to look at increased risk of mortality, diastolic dysfunction was one of 3 factors that emerged. So in addition to age and also a low DLCO or transfer capacity on lung function testing. So we recognize this in our patients. The timing of it isn't really well described. I showed you that slide before about the coexistence of cardiac with other involvement, but the timing for either developing myocarditis, which we assume is often early in disease in the inflammatory phase, or diastolic dysfunction, we sometimes associate with those acute myocarditic episodes, but sometimes can occur over a period of time. That still isn't well described. The importance of this is to say that it has a major impact, obviously, in terms of mortality. As I think probably have alluded to, there's a complexity associated with scleroderma, and so a lot of focus over the last few years has really been on diagnosis, and this is where imaging and a tier 2 sensitive imaging has really emerged as a hugely effective tool, one in terms of our clinical practice, but certainly in terms of the research agenda. The challenge slightly is that when we talk about myocarditis in patients with scleroderma, so primary heart myocardial involvement, we use the definitions that are used in that are applied in the general cardiovascular literature and a narrative. So these are classic definitions that have been typified by use of histology with cardiac MR definition, and I put on the top right the updated Late-Louise criteria to essentially determine what's the likelihood of getting a positive biopsy confirmed myocarditis diagnosis. But these have been developed on really models of viral mediated inflammation, and it's not clear necessarily whether this can apply to patients with scleroderma. And so there's a lot of discussion that whilst the studies I'll show you shortly clearly apply the same sort of principles, there is an acknowledgement, and that's just shown in the cartoon in the figure on the bottom right, of essentially inflammatory myocardial disease separate to myocardial pathology that follows infarct and even viral mediated inflammation that we need to start recognizing to get a better understanding of the underlying pathophysiological processes and also for future target discovery. And so in scleroderma, it's not, like I mentioned, it doesn't necessarily fit within that traditional concept. We don't have diagnostic criteria. So at the moment, we use traditional criteria, but indeed this challenge and unmet need is relevant across our immune-mediated diseases. We often see diffuse inflammation fibrosis rather than more focal fibrosis that is often described, so, and that's through late gadolinium enhancement. And often, as I've alluded to before, diastolic dysfunction and heart failure with preserved ejection fraction is a more common phenotype. So cardiac MR, which I'll come on to, we use more and more to diagnose. But I think if you look in terms of the context of a patient with quite complex multi-system disease that can have multi-organ involvement with a whole host of risk factors, then actually interpretation can become quite challenging. What's interesting to see over these last couple of years is through COVID-19 and obviously the huge amount of research that's now going into COVID-19 related myocarditis, this concept of inflammatory myocarditis and understanding that a bit more distinctly really chimes and resonates, I suppose, with what we see with immune-mediated diseases and scleroderma. Essentially, if we try and pick up where cardiac MR has been applied more and more, is to essentially detect these processes of myocardial inflammation, vasculopathy, and fibrosis. There's been a whole host of studies. I've just really summarized some of the initial insights that we've learned in terms of the CMR studies in scleroderma. As mentioned before, focal fibrosis is well described. This is in a non-coronary artery disease pattern, so it's a non-ischemic pattern. And particularly because of the processes of fibrosis, T1 mapping with cardiac MR has become particularly relevant in identifying patients that may have cardiac involvement. We also see longer T2 relaxation time, so we see features that are associated with myocardial edema and inflammation. And the interesting thing is, as we've used cardiac MR more, we've identified that the signature of reduced and impaired myocardial perfusion, myocardial fibrosis, both focal and diffuse, and the vascular and the inflammation changes that we see with T2. We see this in a subclinical setting. So patients that may be asymptomatic, where we may not have any clear suspicion apart from the risk profiling, we clearly see changes on CMR. And if you were to put a whole load of patients, as I've done whilst I was in Leeds in a study and others have done, up to even 60% of patients with scleroderma will have some kind of abnormality. And so this leads us to this kind of this challenge that we can identify patients at risk. We can even identify those with subclinical heart involvement using very sensitive imaging. Not all those patients present with clinically meaningful, relevant outcomes, which is really what's associated with worst outcomes. So that's where a lot of the research agenda lies at the moment. In terms of prognostication, therefore, there are historical data, and I've just shown this study from one of the French groups that's looked at our standard serum cardiac biomarkers, NT-proBNP, and this was a 3-year survival estimate. This is in patients with diffuse scleroderma, showing those with higher NT-proBNP levels that was associated with the follow-up period with worse survival. In a study that I'd done with one of my rheumatology fellows who was trained in cardiac MR in Leeds, we looked at a subclinical cardiac signature. So these were patients, and actually to be quite puritanical about it, we only included patients with a maximum of 1 traditional risk factor, no past history of heart involvement. And we looked at essentially whether we could identify factors of scleroderma disease and blood biomarkers that are associated with CMR features. On the left, you can see that late gadolinium enhancement, so focal fibrosis, the presence of that was associated with a skin thickening score we use in scleroderma called the modified Rodnan skin score. That's on the top left. Also with diffuse fibrosis, and also presence of digital ulcers was associated. So this seemed to suggest that severity markers of scleroderma, we're using skin as a surrogate, and also the presence of severe peripheral vasculopathy was associated with fibrosis. And then when we looked on the right, if you can see on the right, when we looked at the standard cardiac biomarkers and whether these associated with the presence of focal and diffuse fibrosis, there seemed to be a trend for this. Of course, these are association studies, so it's something just to be mindful of. So then we wanted to also look at the prognostic relevance. On the left was a small pilot study where we actually looked, inserted implantable loop recorders in 20 patients successively in patients with scleroderma, picked up a reasonable number of arrhythmia in half our patients. And essentially there seemed to be a suggestion that, again, biomarkers may associate with significant arrhythmia. In our larger prospective study, when we looked at follow-up of the 70, 80 odd patient cohort in terms of outcomes, and these were a number of outcomes: arrhythmia, myocarditis, diastolic dysfunction, etc. There was a trend for essentially ECV and NT-proBNP being associated with a shorter time to event. So on the top left, NT-proBNP, particularly associated with future events. The Greek group, so many will know Sophie Mavrogenis has done a lot of work in scleroderma, and this group has particularly looked not at subclinical, but actually in patients presenting with suspicion or involvement of heart involvement. So this was a prospective study in diffuse scleroderma, looking at a subgroup that had an acute cardiac event and using CMR to see what was the additional utility of CMR following echocardiography. And essentially this was indicating that particularly, again, late gadolinium enhancement and ECV as well were relevant when they did regression analyses and then these Kaplan-Meier plots to look at the combined event endpoint for those that you can see on the top left in terms of arrhythmia, angina, rhythm disturbance, and shortness of breath. So the common theme is that these features of fibrosis and sometimes also our standard biomarkers appear to have diagnostic relevance and also prognostic. This same group then later published a larger study, so this was 150 patients, identified those that had symptoms or cardiovascular events. And particularly I'm showing here patients that had clinical evidence of arrhythmogenic disturbance. And essentially, I won't go through the details because there were some quite complex analyses done here, but did some regression analyses using CMR and other modalities to look at essentially parameters that were associated with the development of rhythm disturbance. Again, late gadolinium enhancement, T2 ratio, and also LV mass coming up. And then did a decision tree analysis and did a cluster to essentially classify patients in these 4 groups based on abnormal late gadolinium enhancement, you can see on the left, and if it was normal, then the abnormal or normal T2 ratio, and on the right, different levels of late gadolinium percentage focal fibrosis. And essentially, the bottom line of this was the Sanctus score 3-4 that you can see on the right, where there's greater level of focal fibrosis was associated with a higher prevalence of arrhythmogenic disturbance. And you can see the odds ratio I put as well using Sanctus score 1, that's the better profile cluster using CMR parameters with a much higher odds ratio in Sanctus score 3 and 4 for arrhythmogenic disturbance. So essentially, we are now increasingly using cardiac MR, and it may come up in the panel discussion to varying degrees whether it's done as a routine. These were partly part of research studies, but certainly it's becoming increasingly part of our usual clinical management to try and risk profile our patients. The challenge still remains, despite the studies I've just shown you, in terms of identifying those that are particularly going to go on to develop clinically relevant events, and also how we should be tailoring monitoring and whether there's value in serial use of cardiac MR. And I think the jury's still out there, but it might be worthy of some discussion later. In terms of management, I think probably the theme that's coming through from this talk is it's relatively data light. So this is a big challenge in scleroderma, heart involvement, how to diagnose, how to monitor effectively. And with treatment, we are even more in a data light area. I'm not going to focus really too much on the left. So that's standard guideline-directed cardiovascular management for atherosclerotic heart disease, except for arrhythmogenic disturbance in terms of pharmacotherapy and devices. I'll focus more on immunosuppression. There are a whole host of guidelines, as I say, for general cardiovascular treatment, and I won't focus on that. I would just say that because of the role of microvascular pathology and perfusion disturbance in scleroderma, there have been studies that have looked at perfusion imaging. And also, as I mentioned at the very beginning, we use obviously for our patients with peripheral vasculopathy, so with Raynaud's disease, calcium channel blockers and sometimes ACE inhibitors. And there are studies that have suggested that these treatments may influence myocardial perfusion. And this next study is going back to that USTAR initiative I mentioned. So this very large European observational data resource in a sense. This looked at essentially a large number of patients, so 600 patients that had at least 2 visits, and looked at some key outcomes that indicated primary myocardial involvement with a sizable follow-up patient year. And essentially in the analysis that was done, use of concomitant vasodilatory therapy, so this would be for Raynaud's, use of aspirin that we sometimes use for complicated peripheral vasculopathy and digital ulcers. These were associated with a lower incidence of ventricular arrhythmia and block, and as we've sort of come to expect, active scleroderma disease associated with poorer cardiovascular outcomes and endpoints. So there's a suggestion here that some of our vasodilatory treatments, and it sort of feels intuitive, would have an impact on the microvasculopathic process of the myocardium. But the key interest, obviously, is the role for immunosuppression. Again, I'm not going to focus too much on pericarditis. It's interesting we see it in our patients with scleroderma, but not as commonly as we probably see myocardial involvement. But there are standard guidelines, and we've heard a lot in terms of the role of IL-1, the inflammasome as well, and the role of colchicine, indeed, for pericardial involvement earlier. There's some caution with our patients when we may want to use glucocorticoids because there is a bit of equipoise and uncertainty of high-dose steroids potentially triggering renal crisis. But pericarditis, there are standard guidelines that we often use in place. It's really immunosuppression when there's myocarditis, and our patients don't often present with acute myocarditis. It's that more indolent course I alluded to earlier. And again, this slide is really taken from literature in the non-IMID, non-scleroderma evidence base, where colchicine is, as we've heard, for pericarditis is used, and also for myocarditis, targeting that innate immune system, glucocorticoids clearly for both the innate and the adaptive. But there have been emergence of also use of plasma exchange, potential consideration of B-cell depleting therapy, really targeting the rationale for B-cell activation and potential autoantibody, pathogenic autoantibodies that might be driving the myocarditic process. Interesting to note, there was a recent systematic review just last year of the range of treatments that have been used. The paucity of randomized controlled trials was noted, so a large number of retrospective studies and 6 randomized controlled trials of a range of immune suppressants and disease-modifying therapies that showed there may be some supportive data, but not absolutely clear-cut. And I think this speaks mainly to the nature of the studies, the lack of robustness of randomized controlled trials. But certainly within the non-IMID literature, when we talk about that inflammatory myocardial involvement, so virus-negative inflammatory myocarditis, there is now increasing discussion within the cardiovascular world in terms of understanding the nature of myocarditis a bit more, i.e. it's not all the same, whether we look at lymphocytic myocarditis, giant cell, eosinophilic, and now interestingly with immune checkpoint inhibition, it adds another angle in terms of trying to understand the drivers and mechanisms of the myocarditic process. And so this is really just to remind ourselves that there is now increasing work, and with now sequencing technologies and with tissue particularly, there is increasing work to try and identify clusters, subgroups of myocarditic involvement and pathology that can perhaps inform future target discovery and tailoring of therapies. And in the same way for scleroderma, the features are not necessarily the same. There aren't a vast number of tissue-based studies in scleroderma. It's a rare disease, and really biopsy isn't really the norm apart from some European centers. But this is a study on the right. It was a small study. It was only in 12 patients, but it was biopsy-confirmed scleroderma myocarditis comparing to virus-negative myocarditis, just to indicate and highlight the fact that the extent of fibrosis was particularly heightened in patients with scleroderma. And there were features that really emphasized the approach of looking at not just fibrosis as that endpoint of disease, as it were, but the inflammatory and the impairment in microperfusion and vasculopathy. So our evidence base for immunosuppression is low. We have no randomized controlled trial data in scleroderma. There are small observational studies that indicate normalization of cardiac enzymes. As I alluded to before, patients with scleroderma often will have abnormal troponins, and that seems to associate with cardiac MR findings. So there are some studies that have shown some interval improvement. And often immunosuppression is used where there's acute myocarditis and heart failure, and where there is that more progressive decline in function I was mentioning. But there is a lot of disparate approaches to managing this, and this is based more on the art of how we treat patients with scleroderma, extrapolating a bit from not just the other myocarditis literature, but also actually within scleroderma, where there's particularly other involvements such as lung involvement, more aggressive skin involvement, etc. There may be wider indications for immunosuppression, reduced ejection fraction. There have been some studies to suggest it may improve LV function, and there have been some anecdotal reports of this and other scenarios. But I think really the context here is that we have very little evidence base, and so the hope is really that by solidifying the role of cardiac MR, there's potentially a role for surrogate, using imaging as a surrogate endpoint, so that then in future targeted therapeutic trials, we can actually evaluate cardiovascular outcomes, because at the moment, our intervention trials in scleroderma either do this very crudely or don't do it at all. In terms of potential future therapies in scleroderma, I've put up this slide just to highlight that there has been a lot of movement in the area of interstitial lung disease. On the left, the census trial, and nintedanib, that evaluated nintedanib, a antifibrotic, has now become available in lung fibrosis. On the top right, tocilizumab in a phase 3 trial. Its secondary endpoint was FVC, so lung volume, and the FDA has approved the use of tocilizumab. And then rituximab as well, where there are emergent data of the role in scleroderma. And the reason I put this in, even though it has nothing in a sense to do with cardiovascular evaluation, is we don't know whether the fibrotic processes and the targets of the skin, the lung, and the heart are the same. But certainly there's an opportunity here with these interventions we are now bringing into our practice to evaluate about subclinical changes, particularly, and in those that may get overt clinical involvement in scleroderma. And there's a whole pipeline now of targeted therapies that are emerging either in early stage trials or indeed ongoing. And I think it's going to be crucially important that we bring cardiovascular evaluation into that. And so these kinds of initiatives and communities are extremely important, really, to push that agenda forward. So I'm just going to finish on this penultimate slide just to say, when we manage patients with scleroderma heart involvement, whilst my focus has been particularly on primary myocardial involvement, our patients also clearly may have atherosclerotic heart disease on the right. So it's important that we address lifestyle factors. We heard about lifestyle, diet, nutrition in the previous talk. That remains incredibly important. General preventative therapies, to address coexistent coronary artery disease, but then the role for immune suppression with inflammatory involvement of the pericardial and myocardial involvement is unclear, but we tend to use this empirically, but otherwise guideline-directed approach remains our mainstay of management. So I'll end there. I'm sorry about the technical hiccups, so I'm just over time a little bit, but really just to close to say that scleroderma heart involvement, extremely complex, huge unmet needs and challenges in this space. Cardiac MR, I haven't mentioned about PET CT, but we can do in the discussion, has really emerged as a sensitive tool that I think is progressing this field further in our understanding. Intervention trials clearly need to include cardiac endpoints, even if it is hard endpoints in the first instance, but hopefully in the future imaging may have a role here. And immune suppression, as I mentioned, is somewhere where we'd wish to be in terms of more targeted therapeutic trials that look at specific advanced therapies to address the specific primary myocardial involvement. So I'll end there, and I'm sorry about the technical hiccup, but thank you for your attention.
Thank you, Dr. Buch. We're going to be moving into the discussion, the panel discussion. So while we're waiting for everyone to join us, I just will comment that, working in this area myself, it's really interesting how we're having to extrapolate so much when it comes to conditions like myocarditis from myocarditis in other populations. If you look at lupus, for example, so much of what we do is empirical. We have very little in the way of guidelines.
And lupus is in a very similar field in terms of imaging, identifying those subclinical measures of inflammation, maybe fibrosis to a lesser degree, but yes, absolutely.
Yeah, and there's some work that's being done by Dr. Courier, our colleague over at Mount Sinai, looking at subclinical myocardial fibrosis and scarring in patients with rheumatoid, and showing that, and I'm really feel that this would be the same if we look at the lupus population and other populations that they have subclinical disease that we're not aware of, and how that translates in the longer term into arrhythmias and other events is something that's up for investigation.
Yeah, and I think we've started to see some of those studies that fibrosis scar extent of is prognostically relevant. It's just knowing, as you say, how to manage that when there's a spectrum of change that we see in our patients.
So I'm welcoming back Dr. Compher and Dr. Eder. Dr. Akhtari and Dr. Tardif should be joining us as well. Here we go. Welcome back, Dr. Tardif, and I assume Dr. Akhtari will join us in a second while we start the panel discussion. while we're waiting for Dr. Akhtari, since we've just come from your talk, Dr. Buch, there was a question in the chat about whether or not any of the medications that are used to treat scleroderma may actually cause non-ischemic cardiomyopathies. I'm not sure what they're specifically referring to there. You may know.
No, I'm not quite sure which treatment they're alluding to. I mean, we tend to use within scleroderma, as you know, it's mainly vasodilatory therapies and immune suppressants where there is a rationale, as sort of I mentioned, that for it having potential benefit in our patients with non-ischemic cardiomyopathy. So I'm not quite sure which treatment they're saying. I don't know if they can add that to the question and then can give
maybe the person that asked the question can expand a little bit further. And can I just ask you, are you using MRI at the time of diagnosis of patients with?
Yeah, I mean, yeah, and this is what I mentioned. I think it varies depending on the center and facility. So, as I said, the patients with early diffuse SCL70 disease, I would be getting a CMR at baseline to risk profile them, because I think there's sufficient data to illustrate the fact that those patients are particularly at risk. But I have to say that is not a consistent approach. I think we've just done some World Scleroderma Foundation and European Heart Failure Association recommendations, and it needs to be on a case-by-case basis. But I would have a low threshold. Certainly, we certainly check standard cardiac biomarkers, and so that together with echo and the general scleroderma profile might push towards a CMR. But I know discussions with other colleagues in Canada that it's not always available, so it does depend on individual health systems. We use CT chest at baseline in all our scleroderma patients to identify involvement of lung disease, interstitial lung disease. It's the same narrative, I suppose, but I think we need more data to strengthen that and be able to implement it more consistently.
Mm-hmm. Definitely across the different health systems, you're going to have, and within one, I mean, it's not dependent on the country's health system, it's also where the patient is located. We're based in Toronto here, but people outside of Toronto don't have nearly the same access, and I'm sure it's across every country that we're talking about. So we have variability in access and equity.
Paula, if I can ask Dr. Buch, regarding, you mentioned some of the difficulties of studying scleroderma as well as lupus being such a rare disease, and comparing to the cardiovascular literature and the general population where thousands and thousands of patients are recruited, how can we approach this? Should we rely on biomarkers and imaging rather than clinical events, or do you have any other suggestions?
Yeah, I mean, I think that there are two elements. I think imaging is going to be a necessary tool now that it has emerged as such. I think having trials with events is extremely difficult, but the challenge is, I think, these kinds of initiatives, so collaborative exercises, crucially important in rare diseases or less common diseases. There is an argument to look across IMIDs. So, I've done scleroderma studies and RA studies, and you may have done lupus studies. There is a scientific strength and rationale for also looking across IMIDs as well. And I think there will be some complementary approaches. So yes, there may be studies with events, hard events that one can look at, looking at diastolic dysfunction. There's clear data of the prognostic relevance of decline in diastolic function. But in terms of if you're talking about myocardial, those early changes of myocardial inflammation and development of fibrosis and whether interval change, we can try and essentially abrogate that. Imaging is going to become important. And I think looking across lupus, scleroderma, across diseases brings us strength in numbers, as well as actually understanding whether the underlying processes are the same.
Mm-hmm. Dr. Buch, just to finish that question about the medications, it's
right, Humira. Well, we don't use Humira for scleroderma. There is no evidence base for using. So Humira, a TNF inhibitor, and I mean, actually, remember that we had Dr. Eder. You talked about oral surveillance. we use TNF inhibitors almost as our benchmark for improving atherosclerotic cardiovascular disease. So the data on TNF inhibitors has actually been very positive. We've seen improvements and reduction in cardiovascular events. This is atherosclerotic cardiovascular events. We don't use it in scleroderma. There's no signal that's emerged to suggest that there's an interaction that causes primary myocardial involvement. So if it's grade 3-4 heart failure, maybe that's what the question is about, then yes, that's an interesting one. And I think it's something that is going to be probably some people are interested in tackling because of the early data that showed a worsening in heart failure with those who had pre-existing grade 3-4. Rationally, TNF, actually targeting TNF should be positive. We haven't seen, I mean, we don't use these treatments as much in grade 3-4 heart failure and rheumatoid. But I think there is a value actually in re-looking at that. Certainly in scleroderma, we don't use TNF inhibitors.
Okay, thank you. Dr. Tardif, I just wanted to ask a question that someone asked in the chat that probably a lot of the family docs and rheumatologists are wondering. The question was, if the patient has elevated uric acid and they have inflammatory rheumatic diseases, is there any evidence that they should be treated from the start with colchicine? I'm going to jump to Dr. Compher. These are just, I sort of picked some of the questions that seem to be pretty broad-based that I know a lot of people will be thinking about. And it will come as no surprise to you, Dr. Compher, that there was a question about the keto diet and what that may mean for inflammation or being anti-inflammatory. And if it's safe for patients, particularly those with the inflammatory rheumatic disorders, and if there's any outcome data, because we are seeing a lot of our patients choosing to go on the keto diet. So the Mediterranean diet, we know about the DASH diet. Any comments about keto?
The truth is we know less about the keto diet. It hasn't been popular long enough to have longer-term outcome studies such as mortality. And the person who raised this question, I think, is also mentioning inflammatory bowel disease. In inflammatory bowel disease, especially Crohn's disease, some patients report reduction of their Crohn's disease symptoms if they follow a lower carbohydrate diet. It's called specific carbohydrate diet. They don't eat wheat products, and they're selective about the fruits that they eat. We did a clinical trial in patients with Crohn's disease in flare, a large trial, comparing the Mediterranean diet to the specific carbohydrate diet. We gave them the food. We had the meals delivered to their homes. And after 6 weeks, there was no difference in remission of Crohn's between the specific carbohydrate diet, which is what people thought was designed for Crohn's and would be low in plant compounds, lower in plant compounds, and the Mediterranean diet. So it's hard to know about the keto diet. There is a concern that the keto diet may result in improved weight loss, which would be potentially desirable. But the saturated fat intake is quite high, and taking the long view, that probably is not a good idea, which is why I would lean more towards something more Mediterranean or DASH-like in that situation, just because diet does not change things overnight. We're in for a long haul. So you need something that people can sustain. And you can sustain a keto diet for a while, but can you live like that for the rest of your life? So generally, I'm more oriented toward these others that are easier to maintain in your life, and to eat the same food that other people in your family are eating also, which there's more to food than food. There's the social experience and the communication, etc.
Thank you. I think anecdotally, would say that the patients of ours that have tried the keto diet do have trouble sustaining it, even though they achieve weight loss, etc. Dr. Tardif, do you think you will be okay with your mic?
I have no idea. Is this working now? Yes, I think it is. Okay, good. So I think you wanted to ask me the potential role of colchicine in patients with elevated uric acid levels. So a couple of things. I think what we do know is that an elevated uric acid level is a risk marker for future cardiovascular events. That we know. Second, we certainly know that colchicine is an excellent agent for patients with gout. And thirdly, as I said earlier, there is observational data that have suggested that patients with gout that are treated with colchicine have lower cardiovascular event rates than those who are not treated. But these were not randomized data. So you could say, well, yeah, but there's a whole host of reasons, other factors that, may be at play here. But so that's what we know. So I guess if I was faced with a patient that has an elevated uric acid level and has any evidence of coronary artery disease, then for sure I would use colchicine. And basically my threshold would be pretty low. If someone has a history of gout and a family history of coronary artery disease, my threshold would be lower. But strictly speaking, there's no randomized data of colchicine in primary event prevention just yet. We'll be doing, the cold cut primary prevention trial that's going to take, unfortunately, a few years.
So you're using it off label, but it's kind of first principles and hoping that it's doing good and not doing harm.
That's correct.
Yeah. Okay. And just one other question for you as well that came up was about knowledge translation. So there are some big clinical trials now about secondary prevention with the colchicine. One of the comments in the chat was that it sounded like it was coming from a cardiologist, was that despite these clinical trials, and it's being incorporated into guidelines, that maybe it's not translating out into clinical practice. Do you have any comments about that?
Yeah, sure. First of all, well, I think that's normal. Remember the history of statins early in the 90s. I mean, it took a bit of time before they, became widely used. And I remember before the 4S data came out, there were still, there was a healthy dose of skepticism around the potential cardiovascular benefits. So now I think we have two large trials that are complementary to each other. We have some guidelines that have incorporated the use of colchicine in secondary prevention. I think there'll be more trials. There are trials in stroke. There are trials in different fields. I think that I would be very surprised that I see no good reason for not using a pill that's been around for a century and that costs 50 cents a day, and that results in reductions of MI, strokes, and revascularizations by more than 30%. So, but I think it's normal that it's going to take a bit of time. There was that position paper in the Canadian Journal of Cardiology a few months ago with 20 Canadian authors that basically was saying you should consider colchicine for all your patients, not necessarily use it, but consider it for all of your patients with coronary artery disease. And I think that's a start. I think things will change over the course of the next 2 years, probably.
Yeah, translation into practice always takes time.
Absolutely.
Does anyone else have any observations about that with Dr. Akhtari? You work a lot in both general cardiology and cardio-rheum. Any observations?
Yes, so thank you. And about the colchicine use in primary prevention, obviously we're not using it at all in primary prevention setting just yet. But in secondary prevention, just this last week, I've seen a couple of patients in whom we have sort of discussed using colchicine. Patients seem to be a little bit reluctant sometimes because of what they hear about potential side effects. But my experience has been the ones that are higher risk for cardiovascular events that themselves appreciate their higher risk are more willing to try.
Maybe Dr. Harvey, I did not address fully your question because I am aware of the patterns of use, and clearly it is increasing in most parts of Canada, in the Maritimes, in Quebec, in Ontario, in Alberta, quite a bit. So it is increasing. The other thing is about side effects. When you say colchicine, most people think diarrhea. But I tell you what, I may be older than some of the people here on this meeting, but the way I was taught to prescribe colchicine in the hospital 25 to 30 years ago, when someone had an acute episode of gout, was colchicine 0.6 milligrams, and then 0.6 milligrams every 2 hours until development of diarrhea. So guess what? People develop diarrhea. But when you give 0.5 milligrams a day, 5,000 patients, 2 years, there was not a significant increase in diarrhea. So I think the drug is, and that's my personal experience, clearly better tolerated than this idea that we have.
That's true. I'd forgotten that it was dosed until the patient was symptomatic. It's very different now with the dosing strategies that we have. Just checking, because I know a couple of things have come in.
Can I ask Dr. Tardif?
Mm-hmm.
So I agree with you completely. As a rheumatologist, we consider colchicine as a very safe drug and well tolerated. So I guess my question though is that our patients have multiple comorbidities. They need to take many medications, and adding another medication is always, something that might be an issue. Do you think that risk stratifying by CRP level might add something? And I don't know if you had a chance to do subgroup analysis in your study to see whether it's more beneficial in patients with baseline high CRP levels.
Yeah, the answer is no. We would have liked to do that. Intuitively, that would make sense, obviously. We only, both the COLCUT 1 trial and LODOCO 2 trials were investigator-initiated trials. Obviously, these drugs are inexpensive and not supported by the pharmaceutical industry. And so we did simple, pragmatic trials that were geared towards a high-quality answer on the cardiovascular event side. We only had biomarker data on less than 500 patients, so I cannot directly answer your question. Right now, I have to admit, I prescribe colchicine to patients with coronary disease, irrespective of their CRP level. But your point is well taken. If you had evidence of a high CRP level, that would make sense, because we know that the colchicine targets tubulin and microtubules, and it has an effect on the inflammasome and hence the IL-1, IL-6 CRP pathway. So that would certainly make sense.
Interestingly, there's a comment in the chat that surprisingly colchicine is very expensive in the US. I guess they have a lot more rules and regulations about what you can prescribe, particularly because it's not yet been approved in the US.
Well, yeah. So I don't know if I don't want to take too much time, but colchicine has a weird history in the US, and it's because when a company, colchicine was not approved in the US for a long time. When a company offered to put it on the market, and there are editorials written about this, the FDA gave us a deal that is unbelievable for a long period of time and said, if you make that drug available to patients, we're going to give you 20 years of protection and blah, blah, blah. And so for a long time, colchicine was $5 to $8 a day in the US, which is crazy. I told my US colleagues, you can just come to Canada and just across the border and you'll get it at 26 cents a day. The price has gone down. In most cities, you can get it in the US around $2 to $2.50 a day. It's still too high, but the price has gone down.
just highlights the different healthcare systems. So we've really just got time for one more comment or question. I can't believe how quickly the panel discussion has gone. Maybe this is something we extend for our next symposium. I have questions from people in the audience. Anything from anybody on the panel that you want to ask one another? If not, there was a question to Dr. Compher, just for us to finish off. We talked earlier about the processed foods and inflammation. Are there actually natural foods that you're concerned about that may be pro-inflammatory?
That's a great question. Natural foods contain a very complex set of components. As nutrition people, we know about 9 different micronutrients in a tomato, for example. But we also know that the tomato has about 288 as yet unidentified plant compounds. There's more that we don't know than we do know in a given food. Very often, what we know, we know more about the nutrients than we do all these plant compounds. The nutrients sometimes cancel each other out. There may be beneficial and less beneficial components, but the end result is about the same. I think this is an area of active research, but we really don't have adequate data at this point to say this food is bad and that one is good. And I noticed that someone also said in the chat that the liquid formulas, that I stated that sometimes giving those to hospitalized patients improves the clinical outcomes. They are artificial. They are ultra-processed foods, but there are also situations where patients are so ill or where their intestinal function is so compromised that they get a lot more benefit from those particular foods than they do from eating a whole food, which is not to say that's for everyone, but I think there are indications for that, and most people would not view those formulas as unhealthy, even though they are processed.
Always have to be aware of the exceptions.
Yes.
And pragmatism in certain circumstances. So that's a good place for us to finish. I want to thank everybody that's spoken in the morning sessions and participated in the panel discussion. It's been great. I have many, many more questions in front of me that we could talk about probably for the next couple of hours. So thank you very much. At this stage, I'm going to hand over to Dr. Eder, who is going to be the moderator for the sessions for the rest of the afternoon. So thank you, everybody, once again, and over to Dr. Eder.
Thank you, Paula, and thank you again for all the excellent speakers. It is my pleasure to continue or open the second part of the symposium. We have some additional great speakers, looking forward to hear you. And we had a last minute switch in speakers, and we are going to hear now from Dr. Nehal Mehta. Dr. Mehta is a cardiologist, and he's a Lasker senior investigator at the NIH. He completed his training in the University of Pennsylvania and did some postdoc training in genetic epidemiology. And his research is focusing on the role of inflammation in cardiovascular diseases and metabolic syndrome. And his research program uniquely combines methods from translational research, genetic epidemiology, and imaging. He's going to present today on vascular imaging of inflammation in patients with psoriatic disease. And Dr. Mehta, thank you for being with us today. I'm looking forward to hear your talk.
Dr. Eder, thank you for having me. It's always really great. I wish we were together in sunny Toronto doing this as we have in the past. So as I said, my name is Nehal Mehta. Thank you for that kind introduction. Today, I'm going to speak to you about vascular imaging of inflammation in patients with psoriasis. You know, before we start, I always start by making sure we're all on the same page. What's cardiometabolic diseases? So it's subclinical atherosclerosis or disease of the blood vessels, insulin resistance, obesity, or dyslipidemia. Really not called the metabolic syndrome as much anymore for reasons to capture more patients with the disease. So most of us as providers are going to be familiar with a case like this. This is a 44-year-old female. She came in for a general evaluation, untreated psoriasis, and she had a mom who had diabetes in her 50s, father who had an MI in his 50s, and she smoked half a pack per day of cigarettes, but she had no general medical complaints. You could see here on her general medical exam that her diastolic blood pressure is 89, her body mass index is 32, and her waist to hip ratio is 1. Really giving her that apple shape rather than that pear shape. And she had 9% of body surface area covered in psoriasis, mainly extensor surfaces and on her trunk. Here were the labs that she brought in. Her fasting cholesterol was 210 on the right side for my European and Canadian colleagues in millimoles per liter. You'll see her LDL was just at 159, her triglycerides 200, and her HDL 40. And her fasting sugar was 116. Most of these patients are going to be given a CRP. And in this case, it's normal. So I want people to keep that in mind as we go forward. And it was great on the last session. Somebody asked, I believe it was Dr. Eder asked, do we ever stratify these by CRP? Thinking that that may be a way to find someone who has innate immune activation. So here's 44. This is a common case. We see this a lot. Middle age, untreated psoriasis, little bit of risk factors that won't make criteria. I diagnosed her with high blood pressure. She's obese and she has prediabetes. And the question that we normally will get is, what is her cardiovascular risk? I'm not going to bore you today with these details. Basically, we use regression models, and then we'll calculate some cookbook medicine number of what her cardiovascular risk here is. And when you use said cookbook medicine, you get her Framingham risk score to be 9%. I want you to just stop for a moment and think about that 44-year-old patient with psoriasis, a little bit of diabetes in her family history, a little bit of coronary disease in her family history, and she's got a risk score that puts her in low risk. I've been doing this long enough now where you would be remiss not to know that she's not low risk at all. In fact, we published this just last year with our Spanish colleagues, that when you look at people who are called low risk, about half of them have plaque in their coronaries and in their carotids. So we're allowing our patients to leave low risk, but we're really not impacting on them the risk about the inflammation in her psoriasis. So I'll stop here and I'll just allow you to think about, what have we learned over the past 20 years in inflammation? We had a great talk just on colchicine and how it matters. And that all his work started based on this biology 20 years ago, where inflammation has been shown to matter in cardiovascular disease. These are healthy women followed for 10 years in the Women's Health Study. And if you had a high CRP at the study onset, over 10 years, you had a 4-fold increased risk of heart attack. So what we've done is we've looked at inflammation in psoriasis, tried to understand what it is about inflammation that drives cardiometabolic diseases. Now, at a conference like this, I don't have to remind you, it's a cutaneous disease that's associated with arthritic as well as various comorbid diseases. As a physician scientist who's a cardiologist, I've studied this to understand the impact of inflammation on CVD. So during the first half of my program, we spent time epidemiologically looking at, is cardiovascular disease prevalent in psoriasis? And it is. In over 100,000 people, 50% increased risk of mortality. You'll see that that red arrow is sitting right over about a 40-year-old, 43-year-old. So when someone has severe psoriasis, they have about a 2-fold risk of having a heart attack when it's severe during 40 to 50 years of age. And when you look at the bottom left there, you'll see that anywhere between 43 and 59% of that risk, even beyond traditional risk factor adjustments, still remains. So we use psoriasis as a human model to study inflammatory atherogenesis. Through that middle, we use translational methods to understand immune activation, systemic inflammation, and lipoprotein dysfunction. Shown on the right is a tombstone, myocardial infarction across the precordial lead, something that we see all too often in this young cohort. At the United States National Institutes of Health, I've been blessed for 10 years to run this large-scale cohort study. There's imaging visits in the green, and underneath it, you'll see a comparator protocol. That protocol is basically comparing our psoriasis findings with healthy patients, patients with diabetes, and patients with coronary disease. You'll see on the bottom right, we deeply phenotype each of these patients. They each get a PET CT, a PET MRI, and a coronary CTA. They will get bloods drawn for various biomarkers as well as tissues for protein as well as cellular studies. So if you look at the literature up until when we start this journey over the last probably 15 years, we knew that psoriasis was a common disease. It has a waxing and waning course. It has a young age for development of cardiovascular disease. And the last bullet is really what I spent time at the NHLBI trying to understand, is if you have single cytokine inhibition that you can use biologic therapy for, what are the off-target impacts of those? Before we go on, I'd like to remind you that we've started a multimodal vascular bed imaging program at the NHLBI, and it consists of inflammatory burden of atherosclerosis on the aorta on the right, FDG PET CT, FDG PET MRI. And what that is it's looking at CD68 positive macrophages in the arterial wall. On the left, you'll see that we also incorporated coronary CT angiography to directly go where the coronary artery disease is. So the first thing I'll cover is the fact that when you look at 18 FDG PET CT here, you'll see that in somebody with psoriasis, there are 4 cardinal findings. There's uptake in the skin, there's uptake in the joints, there's uptake in the liver, and there's uptake throughout the aortic tree, throughout the whole aorta. Compare that to a normal healthy human that has diffuse homogeneous uptake, really concentrated in the myocardium, the kidney, and the bladder. When one looks at the vascular inflammation in the aorta and compares that to a PASI score, one finds a direct relationship that the more inflamed the cutaneous involvement is, the more inflamed that the vasculature is. It was around that time that we started imaging our post-MI population, and we found very similar vascular inflammation patterns in those having an MI. And so it was that time that we asked, if psoriasis and cardiovascular disease do in fact share inflammatory pathways, might the coronary arteries be affected themselves? So this isn't going to play, it's a PDF, but on the bottom left here, you would see that this is a 3D reconstruction of what looks to be here the LAD. We have these coronary CT angiography scans, 320 slices, and for about the cost of 3 chest x-rays, if you will, for radiation, we get this, this exquisite definition of the inner and outer border here of this non-calcified plaque. And so this is one artery, 4 views. And when one looks at the luminal volume and subtracts it out, one gets the actual thickness of the coronary arteries. And so that's called a plaque volume. So the data, non-calcified burden that I'm about to show you, is actually before plaques have even begun in some of these patients. So we're really getting ahead of the disease process here. First set of data. So in 17, we took our first 200 in the door, compared them to our first 50 volunteers, and we show that there's a 20% increase in coronary plaque compared to age, gender, and BMI matched controls. And then when you look at that non-calcified burden in adjusted models, it's approximately 15% increased in just the sheer definition of having psoriasis. And why I stress that non-calcified burden is important is when we're in the cath lab, the most common culprit of an acute myocardial infarction is actually that non-calcified plaque. Now, what if you actually have a plaque? So now when you look at the plaque that psoriatics are developing, there's 2 high-risk features that are present. And how do we know that? So we asked the question, are high-risk rupture-prone coronary plaques present in psoriasis? And so this was paper in circulation. This was a 38-year-old man with a PASI score of 13. And you see that he had an unfortunate RPL, right posterolateral myocardial infarction, between his baseline and his 1-year visit. So we were able to go back to his baseline scan and find that he had a low attenuation plaque. What's scary about this disease, and if you're not looking up at the screen, this is probably the best slide to look at, that if you're ever trying to show your patients that this is real, just show them this slide, that you're a 46-year-old psoriatic and you have about 1 in 3 chance of having a high-risk plaque. Compare that to someone who's 60 and hyperlipidemic, and you have the same high-risk plaque prevalence. This always gets my patients thinking about, wow, I'm aging my coronaries and my aorta much faster than I should be, and maybe I should do something about that. Story number 2. So I always still look at all my own data. Don't let the reports judge anything. I usually will look at them myself. And this is the 13th set of images that found that after 1 year of therapy, when we were bringing people back, we were finding these 30% plaques being reduced. And so it was there that one of our students asked, does treatment of chronic inflammation modulate coronary disease characteristics? And so over the next 10 minutes or so, I'm going to give you 3 stories. Okay, there's ways of looking at the coronaries. I've shown you non-calcified burden, that coronary wall thickness. I'm also going to introduce you to the high-risk plaque features, which I've already done, but I'm going to show you some data. And then I'm also going to show you some diffuse coronary inflammation, which is, in my opinion, the most exciting development in cardiology in the last decade. So all of these stories published as separate papers are in the same 120 people. There's 90 that start new biologic therapy, and we compare them to 30 with the same amount of psoriasis who just choose not to treat their disease with biologic therapy. We compare their baseline and 1-year CT scans. Before I go through these data, I always remind people these are observational open label studies. They are fraught with confounders. We will try to adjust for confounding, but I don't want you to leave thinking that these are 1A randomized trials, okay? Because the evidence that follows with these are going to get the levels of evidence of these studies themselves. The first point in this group of 120, when you go on biologic therapy versus not, your blood pressure doesn't change, your glucose doesn't change, and your lipids don't change. Great. So anything you see in the coronaries are going to be due to a reduction in inflammation. So we saw a 33% reduction in inflammation in this group. Now, coronary plaque actually, after biologic therapy, improves. And it improves to a point where one will see this lipid-rich necrotic core after 1 year of therapy go away. One will see calcium blooming occur over time, and they'll see that this fibrofatty burden has actually decreased by about half. This is biologic therapy for psoriasis, and it's impacting the coronaries. Think about what the numbers show. Everybody who went on biologic therapy saw a reduction in their coronary plaque by 5 to 7%. That's about the impact of a low-dose statin. The second thing is those who did not go on biologic therapy actually saw a little bit of worsening, non-statistically significant. High-risk plaque, the one that ruptures and kills, went down half in those who went on biologic therapy. 1 year of untreated inflammation, these things got worse by 38 and 33%, the fibrofatty burden being statistically significant. It's at this moment in the talk that I usually pause, and I remind people it's fair to say untreated, unopposed inflammation over 1 year of time, very dangerous for the coronaries. Next, what if you looked at biologic therapy? I did this for this group because I know that each of you does prescribe specific biologics. The most number was 48 went on anti-TNF therapy, and there was a non-significant, but a reduction in their non-calcified plaque. Look at the anti-IL-17 therapy group, 22, down by about 16% and 12% in the non-calcified plaque. Finally, last story. What if you looked at coronary inflammation? So this is peripheral fat attenuation index, PFI, by Caristo Diagnostics. And one will see that at baseline, there's a tremendous amount of coronary inflammation when there's no plaque. After 1 year of treatment with an anti-TNF, that goes down to normal attenuation, suggesting coronary inflammation reduces after you treat the psoriasis. Shown a different way. What if you took someone who didn't go on treatment? No change. In fact, it stayed the same. If you took somebody who went on biologic therapy, anti-TNF, or 1723, all of their coronary inflammation reduced. Finally, what if you applied histopathologic software? You took a coronary and you actually had the ability to then image the coronary, take the coronary out, and then image the coronary. This has been done by this program called Vascular. It's done it for the carotids, and we've used it now in the coronary arteries. And what did we find? When one looks at the lipid-rich necrotic core in this LAD at baseline, 1 year of anti-IL-17 therapy in this patient reduced that lipid-rich necrotic core by over 55%. 55%. So treatment of psoriasis with biologic therapy improved coronary plaque. So what's the take home here? In our 4-year study, which is now out 10 years, in 400 patients or so, we found a ton of dysglycemia and dyslipidemia. However, it's modifiable. Go back to our 44-year-old patient. Unfortunately, this is her. Untreated moderate psoriasis. You'll see that on her CAC score over the 90th percentile. But what's worse is she's developed a serial set of stenoses in her LAD, one of 70% and one of 30 to 49%. So again, she's had elbows and knees psoriasis for many years. It's gone untreated. She has a decent amount of risk factors, but we really wouldn't diagnose them because we're not keeping our eyes open. So what are we going to do here? While we're figuring this out, I think the first thing was the best professional moment in my life was 2018, December 18. Why? Psoriasis made the guidelines for the ACC-AHA. If you have psoriasis, you actually warrant a discussion for early initiation of statins. Made the map. That's great. Now we need to do better than that. The guidelines for AAD, NPF, ACR, and EULAR. I can give you lots and lots of acronyms. They've all addressed this. They've all said, you guys, you got to find these risk factors. In fact, here they're saying multiply their risk score by 1.5. Love that. In conclusion, psoriasis is a systemic inflammatory disease. There's systemic inflammation in psoriasis that's associated with cardiovascular disease. And treatment of psoriasis is important in reducing systemic inflammation. I've left here my Twitter handle. I've also left here my NIH email. And I would like to stop there and remind folks that I've left just a few minutes for questions, although I know we might be coming back for questions a little bit later. Dr. Eder, thank you so much for the invite here today.
Thank you so much, Nehal. It's as always, a great talk and fascinating images. We have a few minutes for a few questions, and then we can address the rest of the questions at the end.
That sounds great.
So I guess the first question that came up here in the chat, and I would like to modify it a little bit. We talk about cardiovascular risk in psoriasis, and we know that it is increased in other chronic inflammatory diseases. So how, are the results that you've shown us, can we generalize them to other chronic inflammatory diseases? And I would like to add, is it important just to suppress inflammation, or the selection of a particular way to suppress the inflammation, i.e. selecting a particular target or biologic medication, is it important, or just suppressing in psoriasis would be sufficient?
That is a great question. Thank you for those on the chat who brought that up. Right now, what I would be able to say is we've looked at this in RA, in lupus, and in psoriasis. And I would say that controlling inflammation matters. How you do it in each disease state, it probably differs, right? So steroids in some, biologics in some, cutaneous control in some. I remind people that in our VIP study, UVB therapy actually was effective in treating vascular inflammation, and it improved HDL function. So I do think that we're at a point where we should remind people treating the primary source of inflammation is important. Do we have the rich data in other disease states? We don't. Houston Methodist is starting an IBD cohort. The NIH has a lupus cohort. We have the psoriasis cohort. And I do think that others are going to follow suit by saying this is important. But my take home to you and the team here, the crowd of people who are caring for these patients, take every source of inflammation seriously, because it will impact downstream comorbidities for sure.
Thank you. Another question that came up here is the management of dyslipidemia, and I know that you're doing now a study on how to intervene and handle dyslipidemia in psoriasis patients. Can you tell us a little bit about how do you approach dyslipidemia in these patients? The case that you've shown us had a slightly elevated LDL. So would you only manage psoriasis? Would you address traditional cardiovascular risk factors as well?
That would be a great way to sort of close the message here, which is, yes, in our patient's case, there's no doubt that when I used to give this case, I would say, maybe we'll discuss a statin. She left our office on Crestor 10 and now continues on it. So what would I have done for this patient? I would have got her to stop smoking. I would have treated her diastolic hypertension. I would have gotten her on some low-dose statin. Now, someone asked, will you start with diet and lifestyle? I would. I do. We have a dietitian. We have an exercise physiologist. But I would tell you that that's only effective about half the time. So I've been starting statin therapy earlier, then I peel it off. What else do I do for these patients? I do have them visit for important dietary recommendations of eating frequently. The low HDL is one where that should be a marker of metabolic syndrome and badness down the line. So what I would do there is I would offer that person very quickly, a handful of almonds, canola oil, 3 portions of salmon a week, 1 avocado a week. So there's certain HDL raising therapies. There are naturally things that you can do. And then finally, Dr. Eder, I do think that in there, somebody did bring up managing the dyslipidemia first. I do it in parallel now. I don't wait to treat the psoriasis. I actually treat it holistically. Let's treat the psoriasis. Let's treat the lipids. And our sugar in our patient is very worrisome. The 116 is very worrisome. So I would do something about that as well.
Thank you. Certainly addressing all of these issues is important. And I find the diet particularly challenging, especially if you don't have a dietitian that can help you advise about diet, because patients would have all sorts of idea that they get from the internet about anti-inflammatory types of foods and all sorts of things. Maybe one last question is, you've shown us many fancy imaging modalities, and I wonder, this is absolutely fascinating, the resolution and the way we can now look into the vessels, but in real life and real practice, would you suggest referring patients to any or even coronary calcifications or something that is simple, or just adhere to the regular Framingham risk score and apply these multiplication factor? What is your approach?
I'm so glad you brought that up, Lihi. So I would actually believe in image-guided therapy here. And what do I mean? I don't mean you need to have a coronary CTA. You could get carotid ultrasounds. You can get femoral ultrasounds. The whole Spanish cohort, Alvaro Quintero Gonzalez's group, does everything by ultrasound. We've now just started CTAs with them. But I would say image-guided therapy is important. Look, for this patient, would we have known she had 3 serial stenoses? No, we would have just kept, petering around, and then she would have had a heart attack in 2 to 3 years or 4 years. So I would recommend ultrasound. I would recommend CAC score. CAC scores are now $125 for anybody above 40. They're covered by insurance if you have a chronic inflammatory condition. But I would believe in image-guided therapy for sure.
Thank you. I'm really glad that you mentioned it, because we do it as well in Ontario. Actually, for patients who are in the intermediate risk group, it's covered. Coronary calcification is covered, and we do have a few cases where patients were classified into a low risk category, and these patients had rheumatoid arthritis or other inflammatory diseases, and founding scores of thousands, and this triggered more.
It triggers better care. It triggers higher level care. So I do appreciate it.
Thank you. So I guess thank you so much, Dr. Mehta, and we'll be certainly glad to have you at the panel discussion. We have now 15 minutes break for people to get some food and stretch their legs. And so thank you, and we'll meet again at 12:40.
Good afternoon, everyone, and thank you for staying with us. I'm really glad to open this last part of our symposium today. We still have some excellent talk ahead of us. And without further ado, I'm really pleased to introduce our next speaker, who is Dr. Michael Garshick. Dr. Garshick is an assistant professor of medicine and cardiology at NYU Langone Health. He was trained in Columbia University and completed the master program in clinical investigation at NYU Langone Health. And his research interests include exploring mechanisms to explain the elevated risk of cardiovascular diseases in patients with immune-mediated inflammatory diseases, and particularly he's focusing on platelets and endothelial cell biology. He holds grants from several granting agencies, including the National Psoriasis Foundation and the New York Medical Society and the American Heart Association. And he also runs a similar program to ours, a cardio-rheumatology program and cardio-rheumatology clinic at NYU. Dr. Garshick is going to present today on platelets and inflammation and the role of aspirin in cardiovascular risk prevention. Take it away, Dr. Garshick.
All right, thank you, Lihi, for the or Dr. Eder, for the kind introduction. It feels just a few years ago I was actually setting up a meeting with you and Dr. Harvey to try to figure out how to start our own cardio-rheumatology program. So it's really great to have come full circle. And these are my disclosures related to the talk today. Okay. So, you know, similar to Dr. Mehta, it's amazing how this overlaps. I wanted to start the morning with or an afternoon with a clinical case, one that I actually just saw a few weeks ago in our prevention clinic. And it's a 37-year-old male who's obese and sedentary with mild hypertension. He's a past smoker, not a current smoker. And similar to Dr. Mehta, he's got this metabolic-like lipid profile. So a lot of overlap in how we're picturing these patients. He's a non-diabetic, and his CRP is only 1.5 milligrams per liter. And for this patient, his biggest problem for him is plaque psoriasis. So he's had it for 3.5 years. It used to cover over 10% of his body surface area. He had joint issues as well. There's a concern for psoriatic arthritis, yet after starting a targeted IL-17A inhibitor, his skin and joints improved dramatically. So this patient was referred to our clinic, and he had some questions, and this is actually going to frame the talk today. Is he at risk of a clinical cardiovascular event, and how does psoriasis impact that risk? If he is at elevated risk, why? And what can he do to lower his risk? And I'm going to focus on some of our targeted platelet and anti-inflammatory dyslipidemic studies, as opposed to some of the biologic studies to potentially lower cardiovascular risk in these psoriatic conditions. So right off the bat, we know this patient actually has an elevation in his traditional cardiovascular risk factors. And I don't have to convince this audience, it's actually quite common in psoriasis, that in general, when you have psoriatic disease, the odds of a traditional cardiometabolic comorbidity, such as hypertension, obesity, diabetes, metabolic syndrome, are all increased in patients with psoriasis with a dose-response relationship between psoriatic disease severity and odds of a traditional cardiometabolic condition. Now, when you take the way we calculate cardiovascular risk is we take these traditional cardiovascular risk factors, age, gender, race, cholesterol, diabetes, blood pressure, and smoking, and we incorporate into risk score. And now if you're low risk, well, then we'll really just emphasize dietary and lifestyle interventions. If you're high risk, then we'll be much more aggressive with our pharmacotherapies. And then of course, there's gray zone in the middle. Now, Dr. Mehta focused on the 10-year risk of a clinical cardiovascular event, and it's actually quite low in this patient, only 2.5%. Well, that's actually because he's young. So age really drives a lot of this risk of having a hard clinical cardiovascular event. But when you look at his lifetime risk, it's actually quite high, almost 50%. Now, on top of that, that's before you even put psoriasis into the equation. So how does that come into play? Well, in order to really understand the relationship between psoriatic disease and cardiovascular risk in some of the studies that we're doing, it's important to understand how atherosclerosis develops. So as a preventive cardiologist, I still fundamentally believe that you need some sort of lipid or lipoprotein exposure. That LDL particles generally translocate through a damaged endothelium. You get T cell adhesion, you get monocyte adhesion, turn macrophages translocating into the intimal space. They phagocytose those lipid particles to become foam cells. There's also a strong contribution of platelets to this process. So platelets we traditionally think of are been involved in atherothrombosis, MI and stroke, but they're also involved in atherosclerosis as well, or atherogenesis. And this whole process encompasses the first stages of atherosclerotic development. So what about psoriasis and its inflammatory contribution? Well, as a brief reminder, in psoriasis, you have this genetic predisposition. It's combined with environmental stimuli, and this generates this inflammatory cascade that eventually leads to myeloid dendritic cell activation with T cell differentiation, which promotes keratinocyte hyperproliferation. And a bunch of these immune cells, which are upregulated in psoriasis, are also felt to be pathogenic in atherosclerosis. Moreover, not just the immune cells, but the cytokines they produce are all pro-atherogenic, such as the IL-6, the IL-1s, and the S100s. And so this process, which has been happening in the skin, has also been happened to translate systemically as well. And I think that most of the audience is quite familiar with this initial study by Joel Gelfand and Andrea Neiman, that at UPenn at the time, where this was kind of jump-started the modern day push to understand the relationship between psoriasis and cardiovascular disease. And using a large UK database, they found that on average, there's approximately a 50% elevated risk in MI in patients with psoriasis compared to those without. And there's also a dose-response relationship, meaning young patients with severe psoriasis seem to have the highest relative risk of an MI. All right, so how does this psoriasis and skin and vascular inflammation promote atherosclerosis, specifically focused on endothelium platelet biology studies? Well, a key step again in the development of atherosclerosis is endothelial damage. So we at NYU really wanted to understand if the inflammation observed in psoriasis was also involved in the vascular endothelium. So in this case, we started at the site of primary involvement, which is in the skin. These are skin biopsies. This is done in collaboration with the Kruger Laboratory at Rockefeller. We took skin biopsies from healthy individuals and patients with psoriasis. The top is immunohistochemistry, the bottom is immunofluorescence. You can see here that in the bottom of the healthy control skin, there's green and very little red, very little inflammation. Then you look at the non-lesional skin. So say you have a psoriatic lesion on your leg, we biopsy the arm. First of all, the blood vessel is a little bigger. There's also more red surrounding that blood vessel than the yellow. There's inflammation within that blood vessel as well. And then for comparison on the screen left, we have lesional psoriatic skin. So first you see dense inflammatory infiltrates. You see a dilated and plump blood vessel. And you see a lot of yellow. And these studies suggested to us, at least at the microvascular level, there's inflammation within the psoriatic lesional skin and distal to it as well. But atherosclerosis happens generally, or atherosclerotic events generally happens in the macrovasculature, not necessarily the microvasculature. So we wanted to take these skin findings and translate them systemically. We have a technique here at NYU called endothelial cell harvesting and biopsy. Briefly, what we do is we first identify the brachial vein. We put an angiocatheter into the vein. We take a wire, put it through, rub it up and down 3 times, and then we isolate and analyze these endothelial cells. So we started the same way we started in the skin, by understanding what was happening on a non-specific level. So this is immunofluorescence of these endothelial cells we obtained from the brachial vein. The top is a healthy control, the bottom is a psoriasis patient. So first, the green suggests that yes, we did find endothelial cells using this process. The blue is the nuclei. The more red, that's the inflammation you have going into the blue. The more NF-kappa beta nuclear translocation you have is present, and the more inflamed and activated that cell is. And you can see quite clearly here, both in the picture and in the subsequent quantification, that patients with psoriasis seem to have much higher amount of NF-kappa beta nuclear translocation when compared to the control individuals. Yet, this doesn't really explain mechanistically what was happening in these cells. So next, we looked at the genes being produced from these endothelial cells. The blue is a control. We have psoriasis stratified by moderate and then moderate to severe on the far right. And you can see that a variety of genes or transcripts coming from these endothelial cells are much greater or higher in the patients with psoriasis than the controls. And there's also a dose-response relationship in psoriatic disease severity and gene expression from these endothelial cells, suggesting potential mechanisms of how the endothelial damage may be occurring and also promoting atherosclerosis. Okay, so thus far, we've shown this, and many others have as well, that the vascular endothelium is damaged and activated in patients with psoriasis. And of course, the next question is, well, how is that occurring? So one thing we study here a lot at NYU is platelets. So platelets again are involved in atherothrombosis, and we also think they're involved in atherosclerosis. We wanted to see if they played a role in psoriasis pathology. So we started the way we started with our NF-kappa beta staining. We started going back to the skin. So we looked at platelets, and to our surprise, platelets were actually found in psoriatic lesional skin. Normal skin's all the way on the right, that's immunohistochemistry. And then, of course, you can see the lesional psoriatic skin biopsies, and you can actually see platelet clumping in those lesions, both by immunohistochemistry, and the green shows that, yes, we also found it by immunofluorescence as well, suggesting that platelets were potentially involved in psoriasis pathology. Now, not only were these platelets involved in psoriatic lesional skin, but they're also highly activated in psoriasis. So we saw greater amounts of platelet p-selectin expression. We also saw a relationship between platelet p-selectin expression and IL-17A. We also saw greater neutrophil platelet aggregates and lymphocyte platelet aggregates in the psoriasis patients. And all of these signals are also felt to be pathogenic in atherosclerosis as well. But yet we wanted to go beyond that. So we wanted to explore what these platelets were actually doing to the endothelial cells. In other diseases that we've studied in our lab, such as HIV or lupus, we've noticed that when you take these platelets, take them out of the person and put it on cultured endothelial cells, you can actually induce endothelial cell damage. So we wanted to understand if that process was happening in psoriasis. So what we did is we took psoriasis platelets, we took healthy individual platelets, and we put them in cultured endothelial cells. We looked at them both in resting and stimulated conditions. And what you can see here quite clearly in the pictures is that psoriasis platelets preferentially adhered to the endothelial cells when compared to the control individuals. So next we zoomed in to really explore what was happening to these platelets. And this is scanning EM pictures from these cultured experiments. And if you go all the way to screen right, what you'll find, and look at the arrow. So first of all, the platelets, yes, are adhering to those endothelial cells from the psoriasis patients. But if you look, you'll see these little things sticking out of the platelets. Those are cellular processes, so they're sticking out of the platelets. The platelets are activated. Then on top of that, not just are the platelets activated, but also the endothelial cells are activated as well. And then we wanted to see what were these endothelial cells producing when the platelets were adhering to them. We saw that these endothelial cells were actually quite angry. They were producing greater amounts of IL-8, IL-1 beta, and COX-2, really suggesting a mechanism of how platelet activation could be promoting endothelial damage in the psoriasis patient population. All right, so far, just to round out some of the factors that may influence the development of cardiovascular disease in psoriasis, there are the clinical variables. Now, there's also the pathophysiologic variables, such as platelets. And the one thing many of us are studying is also the immune signature in psoriasis patients, trying to understand how that might also promote atherosclerosis and cardiovascular events. So we've done platelet RNA sequencing in whole blood RNA sequencing in the psoriasis patients. So we looked at the entire leukocyte gene transcriptome from psoriasis control individuals, and we actually identified a pretty strong inflammatory signature from inflammasome processes. So what is the inflammasome signaling pathway? Well, there's the NLRP inflammasome pathway. It's very hot in cardiology right now. It's not the only inflammasome complex, but it's probably one of the best studied. So it's a multimeric protein complex that assembles in response to damage or injury, and it promotes the pro forms of IL-1 beta and IL-18 into their active forms, goes downstream to produce IL-6, leading to CRP production. Again, CRP is one of the biomarkers that we use to risk stratify general cardiology patients, and IL-1 and IL-6 are both felt to be pathogenic in atherosclerosis. The reason the inflammasome pathway is so hot right now in cardiology is because of clinical trials such as CANTOS. So before CANTOS came out, cardiologists didn't really believe the inflammatory hypothesis of atherosclerosis. We thought we knew mechanistically that the immune system was involved in atherosclerosis, but we know clinical trials really proving that targeting the immune system reduced cardiovascular events. So CANTOS targeted the inflammasome pathway, and they showed that if you gave an IL-1 beta inhibitor to high cardiovascular risk individuals over 5 years, you could get a 15% relative risk reduction in clinical cardiovascular events. So now going back to our psoriasis patients, both that we saw this inflammasome signaling pathway pop up in our blood RNA sequencing as a characteristic inflammatory signature, and also recognizing the importance in cardiovascular world of the inflammasome pathway, we expanded to the next steps. We actually did more RNA sequencing on 40 psoriasis patients and 15 controls. And we looked at the genes that were different between psoriasis and controls, and we found about 400 of them were different. Then we also noticed that there is a relationship between gene expression and psoriatic disease severity. And out of this overlap, we identified this gene signature of about 69 unique genes that were reliably higher in psoriasis patients than in controls. So what did we do? We took these genes and we put them in the pathway analyses, and we started to understand the inflammatory phenotype from the psoriasis patients. And it seemed to center around, again, this inflammasome pathway, IL-1 beta, OSM, which is IL-6 related, TNF. Then we took these 69 transcripts or genes, and we started to compare them to other cohorts we have here at NYU. We actually have a cohort of patients that they're having an active heart attack. That's that MI column in the middle. And just before they go to the cath lab, we actually draw their blood. We do whole blood RNA sequencing. We have another cohort of patients that we've taken their blood at baseline and we followed them prospectively over time to understand who's going to have a cardiovascular event. And what we noticed is that out of these 69 genes, 29 of them were related to patients who were having an active heart attack and also predictive of future cardiovascular events. So kind of defining this high inflammatory risk signature in the psoriasis patient population. Okay, so to round out this figure of, I think, factors that are influencing cardiovascular disease, there are the clinical variables, there's a pathophysiologic variable such as platelets and inflammasome signaling, all related in promoting vascular endothelial inflammation and potentially even cardiovascular events. So I think now, again, in this audience, I don't really have to convince you that patients with psoriasis and psoriatic arthritis tend to be at elevated cardiovascular risk through a variety of different mechanisms. Well, then how do we lower risk in these individuals? So some of the cardiovascular prevention strategies, which are standard to us as preventive cardiologists, include aspirins and antiplatelet strategies and statins, whether it's the anti-inflammatory or the lipid-lowering properties. So if you remember, some of our initial studies were focused on platelet activation, identifying the platelets were high activated in psoriasis patients. And then when we took these platelets and put them on cultured endothelial cells, we could induce endothelial damage. So we wanted to explore more of this platelet phenotype in psoriasis platelets. So platelets don't have DNA, but they actually do have RNA from their mother-ring karyocytes. We did platelet RNA sequencing, and we noted that almost over 500 genes were differentially expressed in the psoriasis platelets, and even some pro-atherosclerotic genes, such as the S100, A8, and A9. Now, pathway analysis kind of confirmed our suspicions that platelets in psoriasis are probably important in cardiovascular disease development, inflammatory response, and inflammatory disease. But we also noticed something else. So we looked at COX-1 signaling. So COX-1 is the key enzyme that produces thromboxane A2, and thromboxane 2 is a potent platelet aggregator and activator. COX-1 is also the enzyme which is inhibited by aspirin therapy. What we noticed was that in patients with moderate to severe psoriasis, platelet COX-1 expression seemed to be higher. We also saw a relationship between platelet COX-1 expression and psoriasis severity and platelet COX-1 expression in IL-17A. Now, we thought we were being very unique and novel and discovering something brand new, but it turns out if you go back in the literature about 30 years, others have actually studied this question as well. This is one of the first studies I could find on platelet activity in psoriasis. The Vmax refers to COX-1 Vmax. The controls are healthy individuals and patients with psoriasis. These authors found that too, that COX-1 Vmax was higher in psoriatic patients than in controls. So based on these platelet aggregation and activation findings and the potential importance of COX-1 in psoriasis, we conducted a clinical trial. We took patients with psoriasis and we randomized them to either aspirin, 81 milligrams, or no treatment for 2 weeks. And we looked at their platelet transcript, their platelet factors, and also their endothelial brachial vein profiles before and after therapy. These are the baseline characteristics of these individuals. They're relatively young, evenly split between male and female, and they're low cardiovascular risk, about 4 to 4.5% of having a cardiovascular event over 10 years. Now, what we noticed in these individuals, when we randomized them to aspirin therapy, there was a dramatic reduction in vascular endothelial transcript expression. So all these transcripts we looked at on the right were all from our initial study showing that they're higher in psoriasis patients. So aspirin seemed to reduce endothelial inflammation in the psoriasis patients when compared to the no treatment group. So then we also measured thromboxane B2. So thromboxane B2 is a downstream metabolite of thromboxane A2. The less thromboxane B2 you have, the more efficacious the aspirin is. And we noticed a relationship between thromboxane B2 reduction and vascular endothelial transcript expression reduction, suggesting to us that it was the aspirin's efficacy that improved vascular endothelial health in these psoriasis patients. Okay, so we've studied aspirins and their impact on platelets in reducing endothelial inflammation in psoriasis, but what are other ways to reduce cardiovascular risk in this inflammatory profile in psoriatic patient populations? Well, so as a preventive cardiologist, I'm very interested in the lipid profile of these psoriatic patients. And what we've seen in some of our preliminary studies is that Lp(a), which is highly proatherogenic, and another lipid particle is upregulated in psoriasis patients. We've seen a relationship between Lp(a) and IL-6 expression in psoriasis. And of course, many people, some of which are in the room today, have shown that in psoriasis, there's lower HDL, higher triglycerides, reduced lipid particle size. We've also done some work in lipid metabolism in psoriasis patients. This was in collaboration with Nehal's group at the NIH. So PCSK9 is intimately involved in lipid metabolism. We've seen actually that PCSK9 seems to associate with vascular inflammation. We also have seen that PCSK9 seems to be a biomarker of inflammation in these psoriasis patients in general. There's a relationship between PCSK9 and PASI, and IL-17A, and IL-6 TNF CRP. So based on the known dyslipidemic profile in psoriasis patients, we actually conducted, and also the pro-inflammatory signature in the psoriasis patients, we actually conducted another clinical trial. We looked at how atorvastatin would reduce or potentially improve vascular inflammation in psoriasis. So again, we took 30 psoriasis patients and we randomized them to 40 milligrams of atorvastatin or no treatment for 2 weeks, and we looked at the vascular endothelial profile. What we noticed was that, again, atorvastatin seemed to cause a significant decrease or improvement in vascular endothelial inflammation when compared to the no treatment group. Then we looked at those patients who had gotten the statin and what happened to their LDL and their CRP. We saw a direct relationship between LDL reduction and vascular endothelial inflammatory transcript reduction. And this was in direct comparison to CRP, where we saw no relationship between changes in CRP and changes in the vascular endothelial transcriptome, suggesting to us that it was perhaps more the lipid-lowering properties of statins as opposed to the anti-inflammatory pleiotropic properties of statins that would improve vascular health in psoriasis patients. Okay, so back to our patient, again, highlighting the importance of imaging. In this case, he ended up getting a coronary calcium score, and it was 4. And even though we consider that low in a 37-year-old patient, that's actually quite high, well above the 70% percentile. So we started lipid-lowering therapy in him. And also, of course, there's a lot of things to talk about with this patient in terms of primary prevention. He should have aggressive management of his risk factors, blood pressure control, lipid control. I obviously believe psoriatic disease should be treated. And I think this aspirin question is very interesting and exciting, but not yet ready for prime time, and we're excited to look at it further. So thank you very much. There are a lot of people involved in this research, and I'd also like to highlight the collaborative work we've done with the Mehta laboratory, and of course, the strong support of the Toronto in terms of getting us jump-started in this whole research endeavor.
Thank you so much, Michael. This was great and talk, and really important because there is really very little research on platelets in our, at least, rheumatic conditions as well as in psoriasis. I don't see any questions yet in the chat, but we do have some time for questions. So maybe I can start by asking, you've shown us that there is a phenotype of platelets, inflammatory platelets maybe in psoriasis patients. And do you think these are sort of bystanders that are affected by the pro-inflammatory systemic milieu, or that they actually play a role in psoriasis? Like, do you see any difference in psoriasis when you treat patients with aspirin?
Right. So I will say there's been one group who's done some urine studies studies, I think using a Michelman model, so some issues showing that when you take platelets out of the equation, it seems to make the skin severity less. I will say we only do about 2 weeks of treatment, so in stable psoriasis patients. So we're trying to take the biologic factor out of the equation. They have to be in stable doses, when we enroll them. So we really haven't been powered to assess on a human level, as opposed to a murine level, what happens when you inhibit platelet activation or aggregation.
Yeah, so more research is needed.
Right, exactly.
I guess another question would be, I know that the topic of aspirin for primary prevention, as you mentioned, is a hot topic and controversial topic. So because we do have a lot of people in the audience who are not cardiologists, such as myself and many colleagues, family physicians, can you maybe tell us a little bit about your approach of using aspirin? Certainly for secondary prevention, but do you use it at all for primary prevention, especially, for example, in patients that you see in cardio-rheumatology, where you image them and you actually do see coronary calcification, but they don't have a history of clinical cardiovascular events? Do you consider aspirin in these patients or any other situations where you think it might be helpful?
Right. So this is a hot topic. Our preventive task force just came out with a position statement kind of questioning aspirin use in primary prevention in general. I will say, there's this, if you think about prevention, when someone has dyslipidemia, we treat their lipids. When someone has high blood pressure, we treat their blood pressure. When someone has hyperglycemia, we treat their glucose. But we have no clinical way of measuring platelet activation or aggregation. We do stuff in the research world, but we don't necessarily measure someone's platelet aggregation before we put them on aspirin. We just say, oh, you're high risk, we should put you on it. So there's this really big disconnect when you think about aspirin versus many of our other prevention medications. And I think that's where lies the problem, because in primary prevention, aspirin prevents cardiovascular events, but it also causes bleeding. And so, as you know, if you take a relatively low-risk individual and give them a medication, the risk of bleeding can sometimes equal the risk of preventing a cardiovascular event. So what we do in our clinic is we use risk enhancers to try to figure out who should be the appropriate aspirin candidate. And there's a few that other people use as well outside of the cardio-rheumatology world. For example, if you have a CAC score over 100, you may have more benefit to being on a low-dose aspirin. If you have an LP-A, lipoprotein over a certain amount, 50 or 90, maybe that also can be a reason to be put on aspirin. So I routinely check LP-A's in all my rheumatology patients. We're pretty liberal about CAC scores and about if we can get at a CT angiogram. Generally, we like to do CACs in the over 40 population, just because it does take a little while for soft plaque to turn into calcific plaque. So then we'll get more of some of the carotid IMTs or carotid ultrasounds as well. And obviously, in specific or germane to the population today, if they are using a lot of NSAIDs and the risk is more than just very low, then I'm obviously less liberal with aspirin therapy.
Thank you. So you did mention NSAIDs, and of course, in the rheumatic patients population, many of them will continue using or use NSAIDs to help manage their pain, even though many of them are being treated with biologics. It's quite common. How do you approach the use of NSAID in the rheumatic population, and would you consider combining aspirin in this particular patient population?
Right. So I think, again, for secondary prevention, when you had a percutaneous coronary intervention or you have severe atherosclerotic disease, I think sometimes we're obligated to use aspirin because it prevents complications from our PCIs, and so it's important to prevent those. In the primary prevention population, there are obviously some NSAIDs that have shown lower cardiovascular risk than others, so we try to stick with those. I'm much less liberal about aspirin for primary prevention, especially when you're taking a lot of NSAIDs. I think getting the LDL very, very low is very, very safe, very, very effective, and frankly, has very little complications. And so that's when I would probably shy away more from aspirin use.
Thank you. So I see no additional questions in the chat box. So thank you so much, Michael, and we
Sure.
will see you in the panel discussion soon after the next talk. Thank you very much.
Yep, thank you.
So we are going to move on now to the last talk of this symposium before a panel discussion, and it is my great pleasure to introduce the next two speakers, who are Dr. Paula Harvey, who you already met before. Dr. Harvey is a cardiologist, and she completed her training in Australia and came to Toronto, and then did some work, important work on women's cardiovascular diseases, in addition to working in the cardio-rheumatology field, and especially among lupus patients. She's the former head of the cardiology division and current physician-in-chief of the Department of Medicine at Women's College Hospital, an FM Hill chair in women's academic medicine. And she's also the co-director of the Cardio-Rheumatology program here. She will be joined by Dr. Tosin Osumtokun. I apologize, and I hope I didn't kill your last name, who has been trained in Ireland, and she's currently doing a subspecialty fellowship in clinical fellowship in women's health, cardiovascular diseases, as well as dysautonomia, and she's also managing many of the patients in the cardio-rheumatology program. And both of them are going to talk or give us present a case of a patient from the cardio-rheumatology clinic, and particularly focusing on pericardial diseases.
Thank you for that kind introduction. Just in the next 30 minutes or so, we're going to describe the spectrum of clinical presentations of pericardial disease and rheumatological disorders. We're going to outline the epidemiology and discuss some factors to consider in the management of these conditions. This is the agenda, so we're going to go over some clinical cases, review the considerations related to the cases. As I said, talk about the epidemiology, and then at the end, discuss our management approaches. As Dr. Eder mentioned, we're focusing on pericardial disease today, and I don't have to belabor the point that there are many cardiovascular manifestations of rheumatological disorders. So I'm going to hand over to Dr. Harvey now to discuss the first case.
Thanks, Tosin. So these are actually cases that we've seen in our clinic, and we just felt that they highlighted some different presentations and things to consider, and hopefully will be of interest to the people participating today. So there will be 3 cases in total. So the first case was a 66-year-old woman who was referred for evaluation of chest pain. She described anterior chest wall pain that radiated to the neck and the right arm. Now, her past medical history was significant for lupus, diagnosed in 1995. This had been manifest with rash, arthritis, fatigue, of course, they will have fatigue, mouth ulcers, pruritus, and pericarditis. She was a previous smoker, and she had a history of hypertension. She was on a combination of hydroxychloroquine, mycophenolate, duloxetine, nifedipine, ramipril, and some vitamin D. When she was referred to us, at that stage, she'd already had investigations that were normal, and these included an ECG, cardiac troponin, and an echo. Now, I'm going to be a little brave here. We thought we'd try a polling question. Now, I know we're talking about pericarditis today, or pericardial disease, but just wondering what people in the audience would think would be the working diagnosis in this patient given her history of lupus, the presentation and the findings. If you would like to just enter your suggestions, we'll give you just a little bit of time. Okay, so it looks like we have 15% or thereabouts ischemic heart disease, which is very fair given everything that we've been talking about today. Pulmonary embolism is important in a patient with lupus. She's not known to be positive for antiphospholipid. She hasn't got antiphospholipid syndrome, but that's important, especially with the character of the chest pain. Pericarditis, definitely a possibility. Myocarditis, yes. Costochondritis, some of the patients come along with this diagnosis. And indeed, anxiety was what she'd been diagnosed with before she presented to us. She was told that she was suffering from anxiety. So if we can back to the slides. Thank you, everyone, for participating in that. It went very smoothly. So when we saw her, a little bit more history, her chest pain was worse on lying on the left side and with deep inspiration. So there was a pleuritic component and a positional component. Her cardiac troponin was indeed normal. Her CRP was elevated at 21. Her echo did show normal LV-RV function. She didn't have any evidence of elevated pulmonary pressures. She had no wall motion abnormalities. Importantly, she had no pericardial effusion and she had no pericardial thickening or prominence on the echo. She'd had a nuclear stress test to look for ischemic heart disease, for coronary disease, and that was normal. As I mentioned, she'd been diagnosed with anxiety and she'd been started on general analgesics because of the normal findings on the testing from the lab tests and her imaging. But in fact, this case really resonated with me because she was in tears when I saw her. She was in so much pain. She was on, if I remember, a fentanyl patch and very disabled by this pain. So what we did was, I was convinced she had pericarditis and we sent her for an MRI.
So this is a representative image of dry pericarditis, so which is what this patient had, in that she had evidence of pericardial inflammation on her MRI with no pericardial effusion. So she did have delayed enhancement, which using gadolinium is a sign or a marker of inflammation in pericarditis. And it's found here, or an image here, with a very intense signal all around the pericardium. This image here is just pointing out that she didn't have any evidence of late gadolinium enhancement in the myocardium. As mentioned, she had normal LV function on echo, and the LV function was normal on MRI with no evidence of scar or myocardial involvement.
So she was diagnosed with pericarditis. So completely normal echo, but very clear findings on her MRI. We managed her as a combination, this is important, between cardiology and rheumatology. So she was commenced on high-dose ibuprofen and PPI for gastric protection. We started her also on colchicine, which is very, you're going to hear that a few times in these cases and very relevant to our presentations earlier today. She couldn't tolerate the full 0.6 BID of colchicine because she did actually develop diarrhea, so she was managed on 0.6 daily instead of BID. She was commenced on up titration of prednisone, and her mycophenolate dose was increased because it was felt that based on her CRP and her presentation that she had a flare of lupus. She was changed from the mycophenolate to methotrexate because she had side effects. And she had a very good clinical response. And when she came to see me in clinic the next time, rather than being in tears from pain and frustration and from really feeling like people hadn't been listening to her, she was actually extremely happy and grateful. And I think we all learned from this case. Her follow-up MRI importantly showed improvement in her pericardial inflammation. So the next case is somewhat different. This is a 65-year-old woman who has very long-standing lupus. When I started to see her, she already had lupus for 40 years. Multiple manifestations, including malar rash, Raynaud's, arthritis, serositis, alopecia, and nephritis. She had positive serology. And I started to follow her in the clinic in 2010. And it was when she was having a serial echo done that I was called to the lab urgently because of the echo findings at that time.
So this woman had a history of a large pericardial effusion. These images are echo images looking at the heart and the pericardium. This is a parasternal short axis image looking at pericardial fluid here. There's circumferential pericardial fluid. This is a apical 4 chamber, and there's a subcostal image here also, which shows a large pericardial effusion.
So she'd actually had a history of a large persistent pericardial effusion that dated back to 1985. And at the time of the initial diagnosis, it's important to point out this was tapped, and it's very important in these patients to exclude any other etiology beyond their autoimmune or inflammatory condition. And there was no evidence of infection. We have to make sure that there's not a important high acuity infective etiology. There was no malignancy. The findings were consistent with lupus, and these findings usually consist of an exudate, low complement, elevated protein. Your glucose may be normal or low, and then they have positive DNA and anti-DNA and immune complexes. And importantly, she had been completely asymptomatic over all of these years. And at the time that she had this particular echo, she had no evidence of a lupus flare. So the management for her has been that, she has this stable chronic pericardial effusion without any symptoms. She's never had any clinical or echo evidence of tamponade, so no hemodynamic consequences. Unlike our first case, this patient had she had a cardiac MRI. We felt that we needed to evaluate the state of the pericardium, and interestingly, she had absolutely no evidence of pericardial inflammation, no thickening of the pericardium, and no features of constriction. So the fluid, but no pericardial inflammation or thickening that we were concerned of. She had a past history of SVT, which had been treated with an ablation, but more recently she was developing some short runs of atrial flutter fibrillation and some NSVT, non-sustained VT. This is actually in the context of her developing some anti-malarial induced cardiomyopathy, unfortunately. And so we are going to have to monitor her carefully, because with such a large pericardial effusion, she is at risk of hemodynamic instability if she ends up having problems with preload because of hypotension from significant arrhythmias. So her current medications include mycophenolate. She is treated for cardiovascular risk with ezetrol and rosuvastatin. She's on some ramipril, and then just some supplements. She's been off prednisone since 2016, and because of the toxicity from the antimalarial, she's been off that since 2017, and she remains clinically stable, asymptomatic, and very active.
So this is the third case we're going to discuss, and this is a 35-year-old man who was referred to us during the earlier part of the pandemic for evaluation of chest pain. So he had chest discomfort that was a little bit challenging to tease out. And, you know, sometimes it was described as a tightness or a pressure, occasionally a sharp pain. Wasn't felt to be significant by the patient, wasn't really limiting his activity, but it was there. And it was the anterior chest radiating straight through to the back. So this man had a long history of lupus as well. He was diagnosed at age 20 and had presented with rash, arthritis, lupus nephritis, and positive serology. A few years prior to us meeting him, he had had a significant lupus flare with pleuritis, pericarditis, and arthritis that required him to be hospitalized in 2017. And when we asked him about the features of the pain that he had at that time compared to when we met him, it was somewhat different. When we initially assessed him, he was on prednisone, 5 milligrams daily. He had been on azathioprine, 150 milligrams daily, and was on hydroxychloroquine. So he had a normal ECG. He had a normal troponin, and his ESR and CRP were also normal. He had had an echo before he came to see us, and that showed normal LV and RV size and function, normal pericardium, no effusion. So on discussion and evaluation, and based on his history and the fact that we didn't really have a clear cause, and there were some concerning features in his chest pain, we sent him for an MRI. So this is a reflective image. In his case, he had circumferential pericardial thickening, edema, late gadolinium enhancement, so significant changes seen on his MRI. Here, similar to the first case, we had joint decision-making with the patient, with the rheumatologist, and he was followed very closely by his nephrologist as well. We were unable to use NSAIDs in this case because he actually had a previous allergy to NSAIDs, as well as a history of lupus nephritis. So his immunosuppression was increased. Prednisone increased from 2.5 to 20 milligrams daily. And this had to be discussed as a team because the patient himself was reluctant to increase his prednisone dose. We also added in colchicine, and we see here he's on a little bit of a lower dose than what we have been talking about. And again, that was because of side effects with the higher dose. So his azathioprine was changed to mycophenolate. And with that approach, he responded very well. Clinically, the chest pain resolved, and he's currently asymptomatic. He has been able to down titrate very gradually the prednisone dose, and he remains on colchicine.
So pericardial disease is really common in the rheumatological disorders. And it's important for us all to understand that the range of presentation of the pericardial impact of these inflammatory disorders can be from a subclinical presentation as an incidental finding, or some of the studies actually have been the autopsy findings, where it's an incidental finding, to significant clinical disease with the risk of complications, whether it's pericarditis with very disabling pain, or effusions, or even constriction. So it's a wide range, and it does need to be thought about. The pericardium is somewhat neglected when it comes to the cardiac manifestations of autoimmune and inflammatory disorders, rather like the myocarditis that we were discussing earlier in Scleroderma, that much of what we do is extrapolated from other non-inflammatory rheumatic disease presentations. So this table here just shows the estimated frequency of pericardial involvement and the type of pericardial involvement in different inflammatory, rheumatic, and autoimmune diseases. This is actually taken from Up to Date. It was just such a nice table that we thought it was worth showing. So you can see in patients with lupus that the estimated frequency is greater than 50% of patients will have some pericardial involvement with lupus, and that may be a pericardial effusion or pericarditis. Rheumatoid arthritis is a little less, it's 10 to 30%. Again, effusion 30%, pericarditis 10%. Systemic sclerosis, symptomatic pericardial disease is less than 20, whereas the overall pericardial involvement can be up to 60%. And again, effusion or pericarditis. Polymyositis and dermatomyositis, it's more rare, so less than 10%. Pericarditis, effusions, and rare case reports of tamponade. Mixed connective tissue disease, 10 to 30%, pericarditis and pericardial effusions, and then Sjogren's, less than 30, pericarditis, Behçet's, rare, and that's pericarditis. Now, even though these frequencies are high, the rate of actual complications that are serious complications, so that would be tamponade from pericardial effusion or constriction, are actually very low in these patients, but they can still cause disabling pain.
So the pathophysiology of the pericardial disease, as was alluded to earlier, is mediated by immune complexes. There's neutrophil infiltration, vascular proliferation, and that's reflective of the late gadolinium enhancement that we see on the MRI. If there is an effusion, it's an exudate with neutrophil predominance, increased protein, lower normal glucose, and immune complexes. So, the two main conditions that we see clinically are obviously acute pericarditis. Acute pericarditis is a clinical diagnosis. So you would have chest pain, pericardial rub, ECG changes, pericardial effusion, and you would need 2 out of 4 of those to make a clinical diagnosis. There are supporting features, fever, raised inflammatory markers, and the patients that we see in clinic are usually patients who have more complicated pericardial disease, and when that's the case, you tend to need more supporting features, and that's where the advanced imaging comes in. Pericardial effusions, as was already mentioned, are pretty common, but they're not commonly problematic. There's a low chance of or low risk of hemodynamic compromise associated with these conditions. Usually you see a small or a trivial effusion that is asymptomatic and found incidentally on echo. So treatment is only if there are concerns regarding complications. Obviously, if there's hemodynamic compromise, then that would be require urgent treatment. If there's a concern for associated pericardial inflammation, then you might consider advanced imaging. And if there is evidence of constriction, then they would require closer evaluation. So, overall, in these type of patients that we see in clinic, the management really depends on the symptoms and the potential for complications. So if we see asymptomatic pericardial effusions, or if they have MRI imaging for other reasons and we see asymptomatic pericardial disease, then we would treat the underlying disease. If they do have chest pain, much like 2 of the cases that we reviewed, you would need a careful clinical assessment and evaluation of that pain. As seen in our cases, we had ECGs that were normal. In one of the cases, we had a CRP that was elevated. Troponins were all normal, so there was no associated myocardial involvement. And we needed imaging, both echo and advanced imaging with MRI for further evaluation. Initial management of the pericarditis itself, again, extrapolating from non-immune pericarditis, is the use of NSAIDs, colchicine. We use PPI cover, and in this particular in these particular conditions, prednisone is used particularly if there's associated activity in the underlying condition. We know that in idiopathic or presumed viral pericarditis, prednisone is not a first-line treatment and has actually been associated with increased risk of recurrence. We do, as part of our Cardio-Rheum program and in association with other specialists, not just part of the program, we definitely are open and we actively work together as multi-specialists. So that's advised where appropriate and where possible. And, there's some consideration, again, looking at the non-inflammatory or autoimmune conditions, people who have significant recurrent chronic pericarditis and complicated pericarditis have been treated with IL-1 inhibitors. So that's something that we don't have data on in our population, but there are some case reports in the use in patients with pericarditis and SLE or rheumatoid arthritis.
So the take-home points are as follows. Pericardial disease is highly prevalent in the inflammatory rheumatic disorders. There's a very wide range of presentations of pericardial disease, from completely asymptomatic, subclinical, found as an incidental finding, through to significant high acuity disease. That you do need to make sure you do a careful clinical history to help you make the diagnosis and plan further management strategies. It's very important, as was the case with the second patient with the big pericardial effusion, that you do exclude other important etiologies that may cause pericardial effusion or pericarditis, particularly infection and malignancy. Also, if a patient is on anticoagulants, then you need to think about bleed as well. Echo is very important to assess for pericardial effusion, for possible myocardial involvement, because obviously it can be both myocarditis and pericarditis. To look for constrictive features, if you are concerned that there may be constrictive pericarditis, it can be very helpful from that perspective. We do need to be aware, as we have pointed out with 2 of our cases, where there was really not, what the first case in particular, nothing to find at all on echo that it required advanced imaging with MRI to actually secure the diagnosis. So in patients with ongoing symptoms, where the echo and other investigations are inconclusive, that then the MRI can be diagnostic, and it can also help to inform what one needs to be doing going forward with respect to therapy. These patients can have recurrent pericarditis, and that's important for us to be aware of as well. Just like patients with pericardial inflammation that don't have inflammatory rheumatic disorders, the first-line treatment where you don't have a contraindication is NSAIDs and colchicine. So we've talked about colchicine is an issue if someone has significantly impaired renal function. We were talking about that earlier today. So renal function needs to be taken into consideration. And same as you have to take that into consideration with NSAIDs and also any other comorbidities that can be made worse, such as hypertension or heart failure, you need to be aware of and careful and be monitoring along with their renal function. They may benefit from a PPI, particularly if you're going to put them on prednisone, for example, which is going to increase the risk of GI complications from the NSAIDs. So first line of treatment, they usually respond very quickly, as was the case with our first patient, but it also for her required some treatment with prednisone and up titration of her immune modulatory therapy. And I just want to re-emphasize about the prednisone that in non-inflammatory rheumatic disorders, we try to avoid prednisone because it increases the risk of recurrence of disease in particular. So it is something that is avoided in the general population, but it is much more recommended and effective in these inflammatory rheumatic disorders. The goal of treatment is to manage the acute symptoms, to prevent complications, induce remission, and to prevent recurrences. And I think the last take-home message that we probably should have put on there, Dr. Oosthuizen, is that the collaborative management where we have cardiology combined with rheumatology, and with one of the cases actually required nephrology, is really important, where we have close communication. Dr. Oosthuizen and I are not competent or confident in managing immunomodulatory therapy, and partnership with our rheumatology colleagues is really important for appropriate management of these patients. So I hope that there are some take-home points for everybody from these cases that we've just presented. We certainly have learned from these sorts of cases ourselves when they come through the clinic. Thank you.
Thank you so much, Tosin and Paula. And I think we tend to focus on cardiovascular and the vasculature system. So I'm really, it's really great that we can talk about some other cardiac structures here. We have a few minutes, and I really want to encourage the audience to submit questions in the chat box, both for the current speakers as well as for our panel discussion. I would invite Dr. Mehta to join us as well. Maybe we can start with some questions about pericardial diseases. And I see a question in the chat box regarding the evidence of constriction by MRI. I would assume that this refers to pericardial disease.
Mm-hmm. Yes, thanks for the question. It's probably referring to the second case, or actually any case that we discussed. There was no evidence of constriction, neither on the echo or on the MRI. Obviously, if there were inconclusive, or there was an inconclusive assessment for constriction on the echo, then that would be another added reason why you would move to advanced imaging. But thankfully, none of our patients had constriction. And constriction would be rare in these types of disorders, thankfully. We have not seen any of our patients with pericardial disease actually have the complication of constriction.
Thank you.
It's obviously something that we need to we monitor for, and if somebody has relapsing pericarditis or relapsing waxing and waning effusions, we're obviously going to be monitoring to make sure that we don't miss any early signs of constriction. So a very important part of the surveillance.
Okay. I have a question about pericardial involvement, and I was taught that pericardial disease in rheumatic patients tend to coincide or correlate with extracardiac manifestations such as in lupus. How common is it to see a patient with rheumatic disease with isolated pericardial involvement without any other manifestation of their rheumatic condition?
Thanks, Lihi. I think it depends on what sort of pericardial abnormality you're talking about. So I not uncommonly will see patients have a persistent pericardial effusion where they don't necessarily have an active flare of their disease. Pericarditis, on the other hand, where you've actually got active inflammation of the pericardium, I haven't seen that where it's been separate from a flare of their underlying autoimmune disorder. So I think if they've got pericarditis where they're actively got chest pain, so they're symptomatic with other features of pericarditis, so you've made the diagnosis, then I would be expecting that they have a flare, and that's been the case for the patients that I've followed over the years. And so upregulation of their immune modulatory therapy combined with the NSAID and the colchicine is really important. They're not going to respond if you just treat them with the colchicine and the NSAIDs. They do need to have their systemic inflammatory disorder managed. The pericardial effusion can be one or the other. Sometimes it's with active disease, and it's sort of like a serositis where they may even have a pleural effusion as well as a pericardial effusion. But it can be just an incidental finding where it's just persistent. So what really interests me in that second case is that she has such a significant effusion with completely normal looking pericardium and has had normal appearing pericardium over the years. And it's quite dislocated from any of the flares that she's had of her lupus, which she's had off and on during the years. And so I don't know whether Michael's got some ideas, but it's almost like she's got a leaky pericardium without it using our tools, which are still fairly primitive, I guess. If you think about it, we're still we've moved on from echo to imaging with MRI, which has made a huge difference in the last few years. But we're still sort of a little bit in the dark. And what is interesting is she doesn't have a pleural effusion, so it's not like she's got evidence of a more generalized serositis. It's just the pericardial effusion it's just separate and stable. The other two cases definitely were linked to inflammation related to their autoimmune disease.
Mm-hmm. I mean, I feel like we see in the non-immune patient population, thank you for including me, Dr. Harvey. I feel like we see in the non-immune patient population a fair amount of mild to moderate pericardial effusions that we will do a chest CT to make sure there's no malignancy, do some inflammatory biomarkers, and then that's it. We won't tap them. We'll just follow them chronically, even large pericardial effusions we'll see. So I definitely think there's a whole cohort of idiopathic pericardial effusions that we just ignore, and they do just fine.
That's true. And in fact, I can think of a few that we're following for a different cohort of patients right now. I wonder what's going to happen. We've had COVID and everybody's focused on the cardiac complications. How many are we going to turn up with incidental findings of small to moderate pericardial effusions? We've seen some because we do autonomic work as well, and we see patients with long COVID, and not an insignificant number actually have evidence of pericardial fluid, so they have small or moderate effusions. So that's a good point. It's an interesting point. And we really wanted people to think about the fact that they are common. It's common to find, particularly the pericardial effusions, and to think about when you need to be concerned. But also to be listening to the patient if they've got chest pain symptoms and making sure you're not missing something now that we've got the additional tool, because I can say in our cardiology world, there's a real temptation to do an echo ECG. If normal, then it's anxiety or costochondritis.
So I couldn't agree with that statement more. I feel like, this is kind of a case of if you build it, they will come. And so as you develop this cardio-rheumatology concept, you're getting a lot of these idiopathic inflammatory conditions where they have concern for pericarditis. And so me and some of the other colleagues in the States are seeing these patients. And I think, we've had a few cases where the cardiac MRI has been very, very helpful to distinguish chest pain. And oftentimes, especially recurrence, I've been amazed how normal the EKGs look.
Yes.
It's usually as you pointed out in your cases, it's usually the CRP that's the tip off to do the cardiac MRI. And it's a lot of times comes with other serositis as well. And then we've given a number now or Lonacept, and it's just been amazing the game changer it's been in terms of treating these patients.
Yeah, thank you for pointing out the ECG as well, because there's a lot of emphasis about the ECG findings, and we're not seeing that
right
in our
especially in
patients.
recurrence.
Yeah.
So I'm glad that you mentioned this, especially the first case that was diagnosed as anxiety. I think, which I guess brings the question of, for non-cardiologists, when do we need to think about pericardial disease? When ordering echo for us or ECG is quite easy, but cardiac MR is much more complex, especially for people outside of academic centers and for non-cardiologists. When would you advise us to refer to cardiology in this situation, especially in a population where already have a lot of pain to begin with, and sometimes it's very hard to distinguish the typical pain from the non-typical pain, right?
Well, the kind of sad thing for that patient was her pain was typical when I first saw her. It was positional, it was pleuritic, it was disabling, and she had lupus, and she had a background history in the past of having actually had pericarditis. And it was disappointing that she'd been seen by cardiology and dismissed. So I think where somebody actually, she has all the risk factors and she had a good history, that she in particular needs to be sent off to be evaluated and with the consideration for an MRI. And I'd say that the third case, which was actually a male with lupus, his pain was a little more atypical, but he still had a history, not of just lupus, but of pericarditis in the past. So I think it's listening to the patient, listening to the presentation, listening to the pain. I'm always very reluctant in this population to say something is anxiety or costochondritis until I'm really, I've done an appropriate workup. And it was sad because she came on a fentanyl patch. So, I think the long and the short of it is to listen to the patient, listen to their symptoms. If you're concerned, if it doesn't fit, then be sending them off for the cardiac evaluation. I know that everybody doesn't have access to people like us, the three of us on the screen here, but one would hope that there's more of a awareness that MRI is very helpful in these patients, just like it is in patients where you're concerned about myocarditis. That both of these conditions, the MRI is really important. And also, she had elevated inflammatory markers. She didn't have an abnormal troponin, so it wasn't that she had any myocardial involvement, but the pain symptoms, the risk factors, the elevated inflammatory markers. Sorry, Michael.
Oh, I was just saying, in this patient population, I want to make a plug for also when you're unclear what the chest pain story is from, microvascular disease, something that we're finding more and more. in doing stress PETs. You know, stress MRIs are probably not as good as stress PETs. I'm not advocating for invasive testing, and very few centers have that, but just to kind of think about the chest pain syndromes a little bit more aggressively than you would if the patient's really requiring a lot of aggressive medications where making a diagnosis can stop some.
That's an important point, actually, because the first case in particular fits that demographic in particular for microvascular disease, so small vessel disease. So she was a woman in her 60s, so a postmenopausal woman. Right. They often do have background cardiovascular risk factors. And so for the non-cardiologists, one of the tools that we have, again, is MRI, where you can do an MR perfusion study to look for microvascular disease without having to do invasive testing. So we do that for some of our patients as well, where you're looking for, an alternative explanation for their persistent pain.
Right. Well, I will say in the States, it's probably easier for me to get an MRI or stress MRI than chronic colchicine use. So last time I had a pay $400 a month for his colchicine, so I excluded that. It was painful. Yeah. Yeah.
So there are some comments in the chat box about anxiety that we should be considered when there is a prior history and not as a default diagnosis. I couldn't agree more. And then there is another comment about pulmonary hypertension that should be kept in mind as well as in the differential diagnosis, especially, I guess, in patients with lupus, scleroderma, and this group of diseases. Any thoughts about these comments?
We didn't see any evidence of pulmonary hypertension in these patients. And again, as in the first case and the third case, their echoes were surprisingly normal. RV function, size, RVSP, IVC, all normal. And none of them had shortness of breath. Really, pain was the big feature in their presentation. But yes, pulmonary hypertension and even pulmonary thromboembolic disease, are considerations. The first case, again, had presented to a local hospital with their pain on one occasion and had CTPA done, which was negative. So yes, that is something that we would keep in mind. So thank you.
And I think, it goes back to one of the first slides that we showed today, which is that one from the Nature Reviews that was on Cardio-Rheum, where they show all of the different potential cardiac and vascular complications of the inflammatory rheumatic disorders. And so I think I thank the person in the attendees for raising that, because we have to go through these differentials whenever we see patients that are presenting with chest pain or shortness of breath or heart failure, is thinking any of these sort of symptoms and sort of clinical syndromes. We have to think about every part of the heart and the blood vessels. So that I show that slide a lot that we showed right at the beginning, because it reminds us all of what we need to be thinking about in these patients. So that's an important point.
I wanted to bring to the discussion the issue of sex here, because again, the first case I thought maybe represents some of the disparities that female patients are having when being assessed or seen by physicians. We know that there are differences in presentation of cardiovascular diseases in males and females. And also in rheumatic disease, this topic has been less investigated, but we are starting to discover differences. So this is a question to all of you. Can you tell us a little bit about what are the considerations that we need to think about when we consider cardiovascular involvement in female patients?
So thanks, Lihi. I mean, it's a really important question. And as you said in my introduction, that's sort of how I got into cardio-rheumatology in the first place, was disproportionate impact on women of autoimmune diseases in general, and therefore a lot of the complications and disparities in how we research and treat women versus men. So, you know, the first thing that comes to mind when you ask that question was that the case that Tosin presented, that was the male with pericarditis, I can tell you there's no way he would have been told that that was anxiety. So I think first up, we have to be aware of our implicit biases of how we interpret symptoms that are being presented to us. And remember that there are gendered differences in how people describe their symptoms. I think we all have to be aware of that, no matter what field we're working in, and there's good evidence to that effect. So a male, biologically male, but with gendered, more sort of female gender characteristics actually they actually suffer from that sort of implicit bias as well. So there's implicit bias related to our interpretation of symptoms and presentations and the way the patients express themselves. There's so many different sex and gender things to consider. You know, I've been working in the biological area for years, but moved into the gendered world as well, because of all of the issues that the different your gender characteristics carry with things, even if it's employment, socioeconomic status, caregiver burden. There's all sorts of things that we have to take into consideration beyond biology. But obviously with biology, there's also things we touched on, the microvascular disease, which is more prevalent in women, particularly postmenopausal women, than in men. And if you look at patients that present with classic sounding angina and have abnormal stress tests, and you do a cardiac cath, and a large proportion of them, particularly women, will have normal in inverted commas coronary vessels, so they won't have obstructive epicardial disease, but they can be shown to have microvascular disease. So that's important. And you know, I can hand over to Michael, but if you're looking at cardiovascular risk factors, one of the things that we have to be very aware of is the change in a woman's cardiovascular risk factor profile over the reproductive phases of her life. And so that's something that we need to be thinking about as well. So as a woman goes from adolescence into her premenopausal years, into her period of years where she may be going through pregnancies and postpartum, and then perimenopausal and postmenopausal and advanced age, all of these different reproductive life stages affect our cardiovascular susceptibility as well to different things, risk factors, pregnancy-related disorders, etc.
Right. I think you know, I think there's actually recognizing, I think, Lihi, what you're discussing is actually a whole field of cardio OB that's emerging within, and it's not actually just focused on the acute complications that can occur in pregnancy, but actually more so the chronic conditions and how cardiovascular risk factors can emerge during pregnancy that are carried through life, such as gestational diabetes, preeclampsia, hypertension, et cetera. And so at every single Cardio-Rheum visit, especially in, you know, obviously in our women, I actually ask about, you know, the OB history, because it's another risk factor, and it determines aggressiveness of care, early menopause, et cetera. And I think also within the women literature, recognizing how the lipid profile can change as you go through menopause and lose estrogen, and how that impacts cholesterol absorption is really, really important. And also, I think another really important concept is, you know, statins are technically contraindicated in the pregnancy. And so recognizing and asking women who has, say, an LDL of 160 when they're young, look, what are your pregnancy plans? Because if they're going to have 10 years of, say, trying to get pregnant and breastfeeding, they may not want to be on a statin for that time period. So perhaps even being more aggressive early, recognizing they're going to have a period off it later in life. So I think there's a lot of a lot of opportunities for prevention strategies that are unique to women, and there's a field emerging recognizing that as well.
Yeah, we ask about menopausal, premenopausal status, postmenopausal status, pregnancy complications, because all of these factors. Age of menarche is important, age of menopause is important, fertility is important, pregnancy-related complications, pregnancy-induced hypertension, gestational diabetes, they're really important as significant risk factors. And if you overlay that onto the risk factor that's associated with lupus or RA or scleroderma, very significant. And then they have all of their related complications with pregnancy and the medications that they can and can't take. And even the birth control pill that we all forget about that is important for cardiovascular risk.
And this will be particularly important in the rheumatic population, where we know that many of them would experience these complications during pregnancy and post-pregnancy. So thank you for mentioning these. It's really important to ask. I wanted to, maybe before we get to the question in the chat box, I wanted to ask you, Michael, having established a cardio-rheumatology clinic and program at NYU, could you share some thoughts and lessons that you've learned from how can we improve this interdisciplinary care, the collaboration across disciplines?
I have to say, I've been very, very impressed with your program and the way you've been able to cross disciplines successfully in sort of your rubric of bringing people in and risk stratifying them. And I'll say that, you know, at least in New York, there's a lot of under-recognized and under-treated cardiometabolic risk in these rheumatologic conditions. And the other challenge we've had is the short duration of appointments in terms of how much time can you spend with a patient. So our rheums and derms are acutely aware of the enhanced cardiovascular risk. That's not new, that's not what to tell them. But it's mostly if you're going to have a 15-minute visit and you have to talk about starting a biologic therapy, that's very complex. And so that can't be done in 15 minutes. So how the heck could you then talk about, hey, you're going to have a 50% chance of having a heart attack in 20 years. I'll see you later. So we've had some initiatives which have been pretty cool. One with Jose, actually, where Jose Scher, who runs our psoriatic arthritis clinic at NYU, where they're just, and everybody, they're checking lipids, hemoglobin A1C, LP(a), CRP, obviously. And then we've had blood pressure, and we've had some cutoffs, and then based on those cutoffs, they'll come see me. And they're very, very loose cutoffs, and so actually they come to me with the LP(a) and the lipids already, and so that's been successful. And it's usually in patients who are already willing to have the conversation. It's a lot easier to do that than the ones who's kind of wave and say see you later. So I think that's been an opportunity that's been nice to explore. But it's definitely a challenge getting these folks in. And despite what you believe about the evidence of if biologics reduce cardiovascular risk or not, I think it's easy way to start that's usually pretty common is just high blood pressure, high cholesterol. They're really cheap and easy slam dunks.
Yeah. Can I ask a question, Michael, about aspirin and biologics and platelet function? Do the biologics have any impact? I might have missed it in the talk on platelet function.
We honestly we have a cohort now that we're trying to study that question, but we haven't studied it. We are now, as part of follow-ups to the initial studies, we're following patients longitudinally, for a natural history study. So hopefully we'll have that answer. But I do not know. And we've done some in vitro work about using IL-6 to activate, that can activate platelets. But we haven't done any in vivo work yet.
We have another question here in the chat box regarding pulmonary hypertension, asking whether normal echocardiogram and normal RSVP are sufficient to rule out pulmonary hypertension. Maybe Tosin, would you be able to respond to this?
Yeah, so thanks for the question. I mean, that is would be a challenging situation, but again, if we evaluate the history and the clinical findings, like we discussed, and we can't, find any other reason, and either ourselves or somebody else is very concerned about pulmonary hypertension, then we would have to ask our respirology specialists. So, that's part of the multidisciplinary and multi-specialty approach that we have. Sometimes we have done everything that we can do in our assessment, and we have to ask for a second opinion or another person to have another assessment. I must say we are fortunate because we do have pulmonary hypertension specialists that sit right next to us. So maybe not everybody has that, but yeah, that would be our approach. I don't know if Paula or Michael have any other ideas.
I think if they have got an isolated DLCO on PFTs, I'd be sending them to the respirologist anyway to be evaluated. Tosin's right. We are extremely fortunate to have pulmonary hypertension specialists that works very closely with us, and in fact works with Lihi and her colleagues. They collaborate. One of the rheumatologists collaborates with Dr. Morick for this very reason, for pulmonary hypertension as a complication of the cohort of rheumatology patients that we have here. So I can't give you a definitive answer, like Tosin can't give you a definitive answer, but I would, with that finding, I would be seeking an opinion from my respirology colleague. Michael, you braver than us?
Especially if they're symptomatic. I mean, I think the flavor here is you can't be experts in everything, is what we're saying. And so I generally, if there's aside from screening for pulmonary hypertension, if they're symptomatic, I would, especially with an isolated reduction DLCO, I would send them off. And, recognizing that if you don't see tricuspid regurgitation or the echo is not good enough, you may not get a
that's right.
Pulmonary arterial pressure to even evaluate it.
Yeah, I really don't like to leave unexplained findings unexplored. So that's where, if there was a finding like this, and as Michael said, has pointed out on echo, there are limitations. Get the patient evaluated, make sure you're not missing something, and then we learn in the process. So everyone benefits.
Going back to interdisciplinary care and collaboration.
Right. It's broad enough.
We are at time, and any last comments, take-home messages to our audience before we close?
Not really, other than just these patients are complicated. If there's anything that you can't explain, then reach out for help, especially to the family docs and the rheumatologists if they need help from cardiology. I think, it's important that you ask for help, and we ask for help from rheumatology if we get patients coming to us that we feel we diagnose rheumatological disorders as well in some of the patients that come to us. So, I think that there's a strong message about atherosclerosis, premature atherosclerosis, unrecognized, undertreated risk factors, and then all the other potential complications we need to be aware of in all of these patients.
I think, anti-inflammatory strategies are finally coming to cardiology. I feel like we're one of the last. So I think that would be a take-home message. You heard about colchicine. We have data on anti-inflammasome. We have an IL-6 clinical trial that's going to be starting. I don't know if, and it's going to be powered not just for atherosclerotic, but also renal outcomes. So I think cardiologists we have now clinical trial data on anti-inflammatory IL-1s in pericarditis. So I think finally cardiologists are getting to the anti-inflammatory mix, and we were kind of the last ones to think about it. So I'll leave you with that.
Information is everything.
Yeah. Well, we have lipids, antiplatelets, blood pressure, now we finally
it's funny because we started with all the big clinical trials, but
right.
It kind of dropped off with we got left behind when it came to all the inflammation.
Yeah, you
Oh,
finally
sure.
came to the right conclusion. So
Right. We had successful stuff, you know.
yeah.
Our anti-inflammatories were stop smoking for many years and lose weight.
Okay, so I really wanted, I guess my last comment is that our program is open for referrals, and to the family physicians and rheumatologists in the audience, we do accept referrals for primary prevention, for secondary preventions, for weird cases. If you're not sure, we are happy to assess these patients. I really wanted to thank all of our speakers. I think we've heard many interesting topics today, and variety from anti-inflammatory approaches to scleroderma and pericardial diseases, and I hope I didn't miss, and in imaging, vascular imaging. And I really hope that you've learned some new stuff and have taken and I believe that many of the topics that you've heard today would be relevant to the patients that you see in practice and could improve care. I wanted to thank our team, and especially Keith Colasso, who organized this day for the 4th time, did a wonderful job. I want to thank the University of Toronto technical support, who helped us overcome some of these technical issues. And thank you for our sponsors. And just a reminder that we do learn from your comments and from your feedback. So please fill out the surveys and give us feedback. We do plan to have this symposium next year as well, and it would be beneficial to know what you liked and what you didn't like about this day. And finally, thank you all for spending the time today on your Friday afternoon and sticking with us. And I do hope to see you next year. Thank you all.
Thank you, everybody.